嘢、減嘢、改嘢嘅有就而家快啲攞出嚟啦嚇。冇啦嘛，咁我介紹下我哋嘅計時器嚇，大家睇呢度呢個計時器。咁咧我都係避免你哋晏晝冇晏晝成績都過晒時嘅時候，每組20分鐘啊嘛，係咪啊？
有人見到呢個計時器有聲，我以為你嘅計時器有聲。
我計時器冇聲嘅，夠鐘先有聲嘅啫。咁如果大家應該有問題咧，自己 set 下，咁打開呢度，然之後撳翻打呢個。如果熄咗咧，請你哋開翻呢個啊 ，Link Top， 咁呢個撳翻 Mini 啦。然之後呢度咧，你打翻2000，即係20分鐘。撳 Space Bar 就開始。唔好再撳 Space Bar 啦嚇，唔好嗱，click 咗呢個之後咧就唔好再撳 Space Bar， 開翻自己個 PowerPoint 先。譬如應該係個咩 Go Free 係咪？
擺 click 啱我哋好緊張，不如你幫我哋撳啦。
我幫你撳。
係啊，用電話一定會撳錯嘢㗎，用電話撳。
我幫你撳啦咁。係
咯。
我都係唔想大家 overrun， 因為你晏晝有堂㗎嘛，係咪啊？係咯，冇飯食嘅，如果話 overrun 就係。咁同埋大家唔使擔心咧，我會問題，因為我今日唔問問題嘅，第一唔夠時間啦，第二我啲問題會放喺你嘅 8-page notes 同埋有啲 comment 咁樣嘅，係啦，咁我諗下啦，我想你哋大家之後點樣跟進嘅，咁可能譬如我會俾個 round 大家改嘢加嘢咧，咁我先至最後 mark 翻分咁樣嘅，咁等下大家有個改過自身嘅機會咯，係啦，得唔得？咁我哋不如我哋 SRA 組點樣先介紹佢啦？我哋歡迎第3組啦，好嘛 ？Frequency Perturbation 即係SC ratio 好嘛？我贏咗。係啦。你哋準備好可以話俾我知，咁我撳掣落去撳掣。唔使㗎，唔使㗎，唔使㗎。大家準備好未啊？
搞人做機會大。
OK。
So we are group 3 and our topic and our measurement is SED ratio and also frequency perturbation, which is also called jitter. And this is our group name, Cassie, Rhoda and Carly. So let's talk about SED ratio. So what is SED ratio? It is comparing the duration of the sustained formation of a voiceless S and also a voiceless Z. So the duration of the longest voiceless S is divided by the longest voiceless Z produced. So you can see the equation here is actually very easy. It's the duration for S divided by duration of Z. And SZ ratio is an indicator of laryngeal pathology. So in a normal case, the SZ ratio should be around approximately 1, while the suspected laryngeal pathology is larger than 1.4. So what is the principle behind? Is that people with normal vocal folds, they will produce the voiceless S and voiceless Z at about the same length of time. So you can imagine it's approximately 1. And however, if the patients with laryngeal pathologies, they will produce a relatively shorter voiceless Z. So it will be larger than 1. So you can imagine when you are producing a voiceless sound, so your vocal folds is actually approximate. So if it is less efficient, so the glottal resistance will decrease and the airflow will increase, and therefore when you are producing a voiceless sound, it will have a shortened time.
So now we would like to invite a student, so we will demonstrate how to measure SZ ratio. Any volunteer? Okay, Clara. So yeah, come on. So if you want to measure the SZ ratio, all you need is a stopwatch, which is a phone, and intensity meter, which is also a phone. So it is really important to keep the intensity constant at a comfortable level. So it's around 70 decibel. So when you produce the sound, it should be around 70 or 80. So it is also important to explain clearly to the client how to predict and. So later, all you need to do is take a deep breath and prolong that sound and sound as long as you can. So now you can try to produce first. Yeah, that's okay. And are your vocal folds vibrating? Yes. Are you ready? So the stopwatch is ready. So look at the around 80 when you produce it. Okay. So Tiffany can.
So it's around 6 seconds.
You want to write that down? So now you can try. Wait.
So it's also around 7 seconds. So you can see it's actually less than 1. So she has a normal vocal folds. Okay, so whether SED ratio is an efficient protocol, we have found an article which is relating SED ratio and a disorder called presbyphonia. Presbyphonia is an age-related dysphonia. So what is presbyphonia? It is because of aging, and due to the aging, there are changes in the coverage, mucosa, muscles, and also cartilage. And also there is a decrease in the elastic fibers and collagen, which is 胶原蛋白. So what they are used for? Elastic fiber is actually responsible for rapidly correct the vocal folds when it is exposed to deformities, while collagen is responsible for maintaining the tension and also stretching of vocal folds. So here you can have a look on this video, which is aging voice.
President Hinckley's words.
It is so great a privilege and so serious a responsibility to speak from this pulpit.
From his early years,
one cannot come to this sacred office without almost overwhelming feelings of inadequacy.
to his latest.
His vocal pitch.
Okay, so I'll pass the time to Cassie to talk more about this article.
So in the paper that Tiffany just mentioned, Vaca asked 104 Spanish-speaking elderly people to participate in the research. So they had a maximum phonation time for 15 and 12 seconds, as you can see here. So the values of maximum phonation time, mean glottal inefficiency, and are the usual limit for voice therapy referral, as they wanted to know whether the SED ratio would accurately detect presbyphonia. A gold standard measurement, the laryngoscopy, was used. So laryngoscopy is a standard method to evaluate glottal competence in phonation. It is very reliable, confirmed by other researchers, and it was found that there were 47 subjects confirmed to have presbyphonia. So to measure the SED ratio, the study did similar thing as what we have just done. So the whole process was repeated 3 times, and the best results were used for calculation. So note that the research did not use SED. So they used A instead, because it was mentioned in the paper that Spanish speakers have difficulty pronouncing a sustained Z. So A was chosen as it has similar production mechanisms in Spanish. So the study used SED ratio 1.3 as the cutoff point for glottal inefficiency. It was found that the SED ratio measurement had a low sensitivity and a high specificity. So low sensitivity indicates that SED ratio may not be able to correctly detect a glottal gap when it is really present. High specificity indicates that SED ratio can correctly detect patients without a glottal gap in phonation. So in conclusion, aspect ratio is a good clinical test for an initial assessment of glottal inefficiency in presbyopia. It is useful to screen out patients without presbyopia, but it cannot confirm glottal inefficiency. So finally, some points to note when we measure aspect ratio. Intensity should be controlled when doing S and Z, because intensity affects the degree of respiratory effort, vocal effort, and laryngeal resistance that in turn will affect the duration when you do S and Z. So I mentioned earlier that it's really important to make sure that the client know how to say S and Z correctly. You should demonstrate for the client before starting the test. A research also found that even with careful instruction and demonstration, people took an average of 7 trials to reach their maximum performance. So now I pass the time to Rhoda to talk about jitter.
So frequency perturbation, which is also known as jitter, it is to describe disturbances or changes of a voice. So a simple diagram here showing where to look for jitter and other acoustic variables on a waveform. So frequency of a speaker's voice vary from one cycle to the next. For example, waveform A on the upper graph might look perfectly periodic, but yet small and random differences in the fundamental frequency from one cycle to the next is indeed present. Waveform B on the other hand, the lower graph, is a sound produced by a patient with vocal polyps. The focus here is to show the frequency variations between cycles can actually be quite contrastive. And to calculate such variations, jitter is used, which is to calculate the average variation in the frequency of adjacent cycles of the vocal folds. Jitter is able to indicate whether a voice is considered to be pathological. Reason being is that normal voices usually had a jitter value less than 1% of frequency variability. Pathological voice, on the other hand, exhibited a higher percentage of jitter, which reflects hoarseness, harsh or rough voice quality of a voice. To further ensure its application and indication, a literature review conducted by Crispin et al. In 2015 suggested that jitter was one of the objective measurements to assess patients with voice disorders. To be specific, jitter may be useful in assessing patients with Parkinson's disease. Since using auditory perception to assess voice is subjective, jitter and other acoustic measurements are suggested. But before we talk about how did our selected article use jitter to measure voice, let's have a quick review on Parkinson's disease. It is a degeneration of dopamine found in the basal ganglia. And one of the features patients with PD display is hypokinetic dysarthria, which affects patients' ability to communicate effectively since their speech and voice quality are affected. So here are some of the speech characteristics of patients with PD, such as alternation in prosody, articulation, phonation, and speech breathing. And one of the features is also a harsh and breathy voice quality, which is also be able to reflect it by using jitter. So how to use jitter to measure voice? The study that we selected recruited 7 female patients with PD and 7 female healthy controls to vocalize extended vowels a, e, and u 3 times for 5 seconds. The reason to vocalize vowel was that vowel characteristics were able to reflect movement of the utterance organ in various positions. Jitter values were then computed and analyzed by Pratt. A literature, again, review suggested that Pratt was an efficient and sensitive measurement or program to measure jitter. So here's a short demonstration on how to click for jitter in Pratt in case we may encounter the usage of it in the future. So we used the sound file, one of the sound files provided by the course instructor. So after selecting her sound file, simply go to the upper bar and found pauses, and then go to voice report and and voila, the blue square lists all the jitter values that you might need. And notice that there's different sub-jitter values on the square. And it is believed that since the article didn't explicitly suggest which jitter values that they use, but it is deduced that they use the first one, jitter local, because it is the average difference between consecutive periods, whereas other, for example, rap or PQ5, they measure two neighboring frequency and also the 4 closest neighbors, which is not applicable into our studies. So in the future, if you want to use this, you can just simply click for the voice report. So for the result, and recall normal, and notice that the first column row, jitter local, is actually 1.319%, which is different from, since normal jitter should be lower than 1%. And notice that it is higher than 1. Reason being is that this sound file is actually not a single vowel phonation, it's actually a VCV structure. So there are more frequency found in the more variation found in the frequency, so higher jitter value is noted. So for the results, and recall that normal jitter value should be less than 1%, and all the patients they have close to or higher than 1% of jitter value in the result of the study, and which echoes to Christman's suggestion that jitter is one of the objective variables to assess the severity of speech disorder and measure quality of hoarseness. So different studies over the years suggested that jitter values were able to reflect voice quality, such as strained voice, hoarseness, and breathiness. And a more recent study suggested that jitter would be low if there was little variation in frequency, which might be useful in detecting variations in changes in voice. So to conclude, Pratt and jitter were useful and was objective to assess voice. And a remark must be noted is that the mentioned study did not use jitter alone, because jitter alone was not sufficient enough to measure voice and laryngeal dysfunction. The researchers also used other acoustic measurements along with it.
Thank you. And in most of the study of jitter, they use jitter value to distinguish between the healthy and pathological vocal folds. In this session, we will talk about another kind of voice disorder which adopt the standard esophageal phonation of Mandarin and Cantonese speaker. Standard esophageal phonation is an alternative phonation method adopted by the laryngeal cancer survivor after a total laryngectomy, which is a surgical procedure of removing a pathological larynx. With the loss of laryngeal structure, a new voice source, the pharyngoesophageal segment is adapted by the SE speaker for phonation. Let's listen to how our SE speaker. Just a few seconds. Oh, sorry. Due to the complexity of the PE segment, the control over the vibratory structure is partially lost. The SE's voice appears to be awkward, atypical, and rough. In tonal language, like Cantonese and Mandarin, the fundamental frequency characteristics are important to semantic distinction, since the word meanings is distinguished by the tones. There are some perceptual studies on esophageal speech on tonal language. They show that SE speakers such as Cantonese and Thai were not able to produce different tones proficiently. However, a later study by Lawrence Ng and his colleagues in 1998 disagreed with these perceptual studies that listeners were able to identify words spoken by the Cantonese esophageal speaker accurately. Another study in 2001, as the figure showed on the right-hand side, we can compare the figure of the typical fundamental frequency of the syllable E of 6 tone produced by normal on the top of the figures, and then SE speaker at the bottom. And the author suggests that the SE speaker were able to accurately produce some Cantonese tones. The SE speaker have been able to vary the muscular tension in the esophagus and hence the rate of PE segment vibration. We have selected two literature on acoustic measures of Cantonese and Mandarin SE speaker. The reason why we picked these two was that the testing materials of the studies was different. Studies in Cantonese used the vowel prolongation E at a high level tone, which was consistent to most of other previous jitter study. However, the study in Mandarin speaker was interesting. They used a tonal language specific testing material which were 4 tones using 2 syllables, ma and ba. So they were testing ma, 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 ma. The results, before I talk about the results, let's have a recall of your memory. Can you tell me the normal jitter value should be less than 1 or more than 1%? Yes. So the normal jitter value is less than 1. The result of both studies show that the SE speakers have the higher value of the normal speaker.
Interestingly, we found that the jitter value of normal Cantonese speaker is lower than 1%, while the Mandarin normal speaker shows a higher jitter value than 1%. The author didn't account for this value, but we think that maybe due to the tonal syllable effect, as the syllable are not steady as one frequency at all, and they use the CV structure as well. The Cantonese studies indicate that the SE speaker had a poor voice quality in which the results were consistent with other previous studies, but the reliability of jitter value was questioned since jitter value were significantly different when the length of the sound sample was altered. The results of Mandarin study by Liu and her colleagues indicate that the SE speaker had a poor control over the PE segment when compared to the normal speaker in controlling their normal larynx, and therefore their voice stability was reduced. The p-value in the study were significant. However, the study didn't recommend or question about the jitter measurement. Last but not least, let's discuss the application to the Cantonese population. According to the two studies, the Cantonese only use the E at high level tone to measure the jitter value. Although the results was consistent to other previous studies, the testing material was not specific to the Cantonese tones. However, the Mandarin study looked into 4 tones of Mandarin and compared the jitter value between the normal speaker and the SE speaker. There is no similar study specific to tone done on the Cantonese. May we suggest that further studies should be carried out on investigating the jitter value in 6 tonal syllables to diagnose sound disorder in Cantonese population. This is the end of my presentation. Thank you.
有問題啊 ？Any questions? Do you have any questions before? You can ask questions to check their understanding.
They understand the jitter value should be
Okay, thank you. So group 6. Vocal intensity and amplitude perturbation shift.
Okay, good morning. We are group 6 and we are going to talk about vocal intensity and schema. And first we will talk about vocal intensity. Vocal intensity should be very familiar to all of you, and it is the amplitude of the waveform measured as dB and perceived as loudness and associated with the lung pressure and the amount of tracheal energy and related to respiration. And the measurements of vocal intensity, usually the noise level is below 45 dB, and there is a sound level meter with microphone on the table, and the distance between the sound level meter and patient usually is arm length distance, and the clinician is just sitting at the other end of the table doing the recording for the patient. And the clinical relevance for vocal intensity is thus it can be used as the measurement of the treatment outcome of patient having Parkinson's disease with hypokinetic dysphagia. Hypokinetic dysphagia patients usually have a low volume of voice, rapid voice quality, short rush of speech, and imprecise articulations. And the reasons behind is that usually there is dysfunctions in the basal ganglia, there is rigidity in the respiratory and the laryngeal muscle, just like the picture here, and resisting the vocal fold vibration and the vocal fold count fully adapt. So patients usually have low volume of voice and rapid voice quality. And in the article called A Retrospective Study of the Voice Before and After the Lee Silverman Voice Therapy, vocal intensity is the only measurement of the treatment outcome of this voice therapy. And in the article, there were 52 male adult patients and 26 female adult patients having hypokinetic dysaxia, and they received treatment called Speak Out Therapy Program, a kind of Lee Silverman voice therapy. And the patient is they're pumped by with the purposeful focus on increasing the vocal loudness during the speech. And the vocal intensity is measured under three speaking conditions: sustained vowel, reading, and conversations. And the vocal intensity is measured across different time: pre-treatment, post-treatment, 6-month follow-up, and 12-month follow-up. And you can see that there is the largest treatment effect, and that means the significant increase in the vocal intensity, around 17 dB in sustained vowel projection. That means the red line here. And the treatment effect is not that big in reading and conversation, because reading and conversation actually require connected speech, and that is variable in the intonation patterns and resulting lower mean intensity level across utterance. And the research states that there is significant increase in the vocal intensity, around 5 to 17 dB for all three speaking conditions, depending on the measurement period. And the treatment effect can remain up to 1 year post-treatment. And we do think that vocal intensity can be the measurement of the treatment outcome of patients having hypokinetic dysaxia due to two statistical values. One is called D value and the other one is called P value. And the D value actually is the effect size, measuring the difference between the two means divided by standard deviations. And you can see that in our research article, for all three speaking conditions and all across different time, actually the D value, basically over half of them are actually larger than 2.3, and which means very significant D values. And also further the analysis using the MANOVA, for the P value, actually all conditions and across different time period, the P value is lower than 0.001. So we do think that the patient, after receiving intensive speech therapy program, this speech therapy program actually effective in increasing their speaking intensity. Therefore, the vocal intensity can be used as the measurement of the treatment outcome impacting disease with hypokinetic dysaxia. And then Emily will talk about trauma.
Thank you. So next we'll talk about another acoustic measure related to vocal intensity, which is shimmer. Shimmer is also called amplitude perturbation, 振幅擾動. Perturbation means disturbance, and shimmer is a cycle-to-cycle difference in peak amplitude. Peak amplitude, which is shown there at the peak. And that cycle-to-cycle difference is usually the result of vibratory variation of vocal folds during phonation. Excessive shimmer could be a result of reduction of glottal resistance and mass lesion or abnormal growth at the vocal folds. It's often associated with the perception of hoarseness in the voice. It indicates vocal pathology, but is not able to indicate any specific abnormalities. Here are a couple of illustrations of shimmer and how it's different from jitter. With shimmer, you can see here, the periods between each cycle, which is on the x-axis, is constant. They only differ in the y-axis, which is the peak amplitude of each cycle. Like I've mentioned earlier, shimmer is closely related but different from focal intensity, and this is a table summarizing all the differences. Focal intensity is the absolute amplitude of the phonation, whereas shimmer is the degree of variation in that peak amplitude of each cycle during that phonation. Focal intensity can be measured in sustained vowels or connected speech, whereas shimmer could only be reliably measured with sustained vowels. The two measures are inversely related, meaning that when vocal intensity increases, the shimmer value tends to decrease. Shimmer is most commonly measured in either dB or percentage. dB refers to the absolute mean difference in amplitude, whereas percentage refers to the percentage of that difference out of the mean total amplitude. If you use Pratt to measure your shimmer, besides dB and percentage, you'll also find APQ, which means amplitude perturbation quotient. It's a little complicated, so we will not go into detail, but just know that if you see this in Pratt, this is what it means. But usually it's shimmer is measured in dB or percentage. So how is it exactly measured? There are some recording conditions that researchers have proposed. Brookman has published quite a lot on the topic of shimmer. Together with her team, she found that shimmer calculation is the most accurate and reliable only when the phonation is about the intensity threshold of 80 dB. Remember that shimmer is inversely affected by intensity, so Brookman is saying that the negative effect of that relationship is minimized above 80 dB. Also, the vowel ah should be used over other vowels such as e or u, which were found to generate unreliably higher shimmer than ah. The pathological threshold of shimmer is around 0.5 dB, meaning your voice is considered healthy or normal if your shimmer value is below 0.5 dB. And here is a table by Brookman showing just another illustration of how when dB increases, here shown on the first line, shimmer decreases. And gender also has an effect on the shimmer value. So obviously that sensitivity to factors like intensity level and gender poses considerable limitation to the reliability of shimmer measures. And here Brookman shows the degree to which shimmer is affected by intensity, much higher than jitter. Results comparison can also be difficult because of the different units we could represent shimmer with. So you'll find studies reporting shimmer in dB or some in a percentage. The reliability of the measurement is also affected by background noise, the quality and model of the recording device, and the placement of the microphone. So now we'll see how it looks like on Pratt. First of all, here are two sounds. One with shimmer in normal range, and one doesn't. I'll play them and see if you could identify the one with presenting a higher than normal shimmer. This is sound A. Can you hear? A.
Abnormal, right?
Abnormal. A. B. So it's not that easy, right? Abnormal shimmer cannot be easily detected by human ears. A normal sounding voice may actually be abnormal. A normal sounding voice could actually be abnormal. The abnormal sound is sound B, and it's actually my voice. So therefore, we need acoustic parameters or programs like Pratt to do precise calculation for us. Okay. So this is sound A. You can see the waveform here. And keep in mind that shimmer is the mean difference in the peak amplitude of the waveform, which is these stuff. And it shows the vocal intensity here, which is above the critical threshold of 80 dB. And shimmer value is 3.9% and 0.3 dB. Recall that a healthy shimmer is below 0.5 dB, so this is considered to be within healthy range. This is sound B, this is me. Focal intensity as well, again, over 80 dB. And shimmer values here is 6% and 0.5 dB, 0.56 dB, which is higher than the critical threshold or the pathological threshold of 0.5 dB. Now, Irene is going to show you how exactly to do it in practice. Okay, I need a volunteer, please. Come. Okay, so what I'm going to do is going to open a Prague program and I'm going to show you when you record a sound. Okay, I'll teach you to do a sustained phonation of 2 seconds. Okay? What do you do? You just say ah.
Okay, for 2 seconds.
Yeah. Okay. Okay. Okay, go. Ah. Okay. Thank you. Okay, now I'm going to show you how we're going to see it in Prague. So this is Cassie's voice. This is the waveform. Okay, so what we do, we're going to take two seconds of a voice here. Okay, so actually we can select exactly 2 seconds from 0.7 to 2.7. Okay, then we're going to check out. Okay, so this line we see here in yellow is intensity value, and the intensity is at 85 dB, which is past the 80 dB threshold. Next, we're going to take a look at the voice report. We need to show pulses, and we do the voice report here. So let's see. This is very healthy shimmer. I can see. Yeah, 0.1 dB, which is within the normal range, right? So this is how we can use shimmer or Prague to do a recording. Okay, so now that we have seen how to play with Prague, we're going to continue to look at what is the clinical relevance of shimmer in these two disorders, vocal polyps as well as unilateral vocal cord paralysis. This is our first study, which is a longitudinal study of voice before and after surgery for the removal of a polyp. Our sample size consists of 5 male adults, all reported roughness with a polyp or 1 vocal fold. And there were 3 measures used. The first one, acoustic measure. The second one is a subjective estimation using the GRBS scales. The GRBS scales is an auditory perception scale, which is the grade of roughness, breathiness, aphasia, and strain of voice. And also the patients were asked to do a self-estimation of their own voice. And the acoustic measures were measured using Prague, which includes F0, jitter in percent, shimmer in dB, HNR, and the degree of voice breaks. And the measurements taken at 3 time points before the surgery, 1 month after, as well as 6 years after the surgery. Conditions for recording was in a soundproof booth. The microphone is 30 cm away from the patient's mouth, and the patients were asked to do a sustained vowel R for 2 seconds. And this is the results. The mean shimmer measurements in dB before surgery is 1.0 dB, which is within the pathological range. 1 month after surgery is 0.4 dB, and 6 years after surgery is 0.42 dB, and these two values is within normal limits. So taken together with other acoustic measure, the pre-surgery voice is pathological, and after surgery the voice quality improved to within normal range. However, after 6 years there was some deterioration, but it was not significant. So you can see here there are other acoustic measures that were taken, and the results from the acoustic measures actually agree with the phoneticians and patient subjective estimation of voice quality. Evaluation of this paper. It is a small sample size of only 5 patients, so it would be good if we have more participants. This paper also included clinical variables such as the size of the polyps. But previous studies by the same author showed that all the clinical variables did not affect the shimmer value significantly. And it also had a good measurement of the acoustic variables. And it also included T and P values like what we see here in this table. So there was a highly significant difference before surgery as well as 1 month after surgery, and another highly significant difference before surgery as well as 6 years. Okay, so but there was no significant difference between the 1 month and 6 years. Okay, so it indicates that Schimmer measurement is useful in assessing significant changes in vocal performance before and after treatment. Now I'll pass on to Maggie, who will tell you more about our next study.
Thank you, Irene. The next study is about unilateral vocal folds paralysis, which is a study for Cantonese speakers. It includes 6 Cantonese-speaking male and 4 Cantonese-speaking female adult patients. The method of the study is to ask the patients to have a vowel prolongation of E as high level tone, and the measurements are obtained twice before injection, 1 month post-operation, 3 months post-operation, and there's no control for loudness. So they only produce the prolongation of E at comfortable levels of loudness. The acoustic measures are obtained using prog, including jitter, shimmer, and noise to harmonics ratios. Here is a result of the studies. We can see that for pre-operation, the mean is 1.042 dB, and for 1 month post-operation and 3 months post-operation, the shimmer value has been decreased. So this has concluded that the use of injection laryngoplasty has significantly improved the voice quality in unilateral vocal folds paralysis patients. And here are some evaluation of the studies. We can see that there are statistical evidence of the effectiveness of shimmer measures used in the studies. For between pre-operation and 1 month post-operation, and also between pre-operation and 3 months post-operation, there have been significant differences in shimmer values. But notice that because extreme large variability inherent in pathological voice signals are found in the study, so the perturbations analysis appear to be questionable, and the measures therefore may not be reliable. So a little conclusion, shimmer is used to measure treatment outcomes in patients with vocal folds dysfunctions, for example, polyps and vocal folds paralysis. And here comes conclusions of our presentation. We have discussed vocal intensity and shimmers in our presentation, and here are some differences. Vocal intensity measures the absolute peak amplitude, whereas shimmers measure variation in peak amplitude. And vocal intensity is applicable to sustained vowels, phonations, and connected speech, while shimmers is applicable to sustained vowels or phonations only. The relationship between vocal intensity and shimmer is inversely related. And here are some similarities between the two measures. There are measurements that used to determine the treatment outcomes, and we need to include other measures for complete voice quality profile in addition to vocal intensity and shimmers. So here are references, and that's the end of our presentation. Thank you.
In group 6, the next group is group 5, presenting voice range profile. The next group. Okay, let's start.
你點樣落色先？你開始計時追求呢
一樣四晒，點綠色咁色？
自己點一次綠色。四晒。誒，得啦，開始啦。Good morning, everyone. We are Group 5 interested in the topic of voice range profile. This is Kara, Victor, and Eunice. And the voice range profile, abbreviation of VRP, has another name called phonetogram. To be simplified, VRP is a two-dimensional image of voice frequency and in amplitude. So you can see from the graph here, the x-axis is fundamental frequency, which presented by the semitone. And semitone is not a linear function, and when you go up the pitch scale, each semitone consists of slight change in frequency than the semitone below it. And the y-axis is the voice intensity. So let's look at a short video in how it demonstrates how the VRP is recorded and manipulated.
The first step is to calculate the pitch range.
1, 2, 3.
是哪位？
Let's see how high it goes. 1, 2,
3。
So up and then we go down, and then now we skip a little bit and see how we can measure the intensity, which is right here. Very quiet, that's why you can't hear.
as loud as you can.
The same tone as loud as you can. Yep, I think we'll give a pause here. Thank you, YouTube, and thank you.
So just now the vowel R was used because it's relatively high first forming frequency than E and U, which may affect the recording of the lower intensity contour. For the instruments that have been used, just seen, it's in the standards of UEP. And then a tone generator, it's for the manual program. If for computerized program, it's also can be used. And then you can use for the microphone and or sound level meter for recording the tone. And with the 30 centimeters mouth to the microphone, and it's in calibration
calibrated such that the intensity pick up at 5 cm from mouth to the microphone distance will be equivalent to be picked up by the microphone positioned 30 centimeters away from the mouth. So room acoustics, normally the voice is not exceeding the 40 dBA. For the second part of the presentation will be the acoustic analysis for diagnosis. Mainly for three features of VRP, we will look at the shape, enclosed area, and then speaking range dynamics. For the shape, the general shape of VRP is complex, and the VRP shape is reported by the minority of the articles. The sum of the two overlapping ellipses, and the second features will be enclosed areas, which is the connection of the lines of loud contour and the loud phonation contour minus the soft phonation contour. It will be the enclosed area that reflects a subject's phonatory capabilities. And the third one would be the frequency range between the frequency minimum to the frequency maximum. Which, it can be calculated in the formula is 39.86 log F max over the F min. So semitone, as I just mentioned before, is used in the frequency axis, but it's not in the linear functions. And it also look at the intensity range. Intensity range is you can see here it's the maximum amplitude, and here is the minimum amplitude. So the differences between it is the intensity range. For dBA, it would be used in a weight range, which is the weighted maximum amplitude minus the weight minimum amplitude. So I'll pass the time for Clara.
Thank you, Carrie. So actually, having all the parameters as mentioned by Carrie, but these parameters are actually the most crucial, which are commonly used in research papers, research studies for diagnostic purposes, which includes the frequency measures, maximum minimum range, the intensity measure, highest lowest the range, and the profile areas. We recall that dB and the dBA refer to the weighted and the non-weighted dB. So question time to make sure you understand everything, which you should be able to do it. So which color line represents the highest frequency? Blue, red. Highest frequency, yes, very good. I almost got it wrong. Which between what colors represents the range of the intensity? Blue and? Excellent, brilliant. Which is the minimum intensity? What color? Very good. Which one is not a linear graph? Which side? X or Y? Non-linear. Because of the semitone is a log function, so it is the x-axis, which is the frequency. Brilliant. So that's the key point which we need to keep revisiting for the whole presentation since the paper are using them. And to look into the voice range profile and the clinical implications, researchers show that they are actually there to assess information about individual voice potentialities, to investigate the influence of therapy, which is a pre and a post, which we're not going to focus on today, and to compare the phonetochrome of different selected groups like genders, age, and so on. And more importantly, it can also be used to give visual feedback for patients to develop a greater vocal range, for example, professional singers. And also in other cases, I've mentioned that, professional singers, transsexual speech, and we can understand one person's voice changes over time. So let's look into the normal population. Question time, easy and simple. What's the differences between a male and female's voice range profile? Is it shifted to the right, left, upwards or downwards? Yes, right, because the frequency of a female is higher. Exactly, brilliant. And we can see from the paper, it's exactly what you predicted. Shifted to the right for females because of higher frequency. And the table in here gives you the further details in terms of data and information for each parameters. And nevertheless, we can see that in terms of intensity intensity measure, it was relatively similar. However, for the frequency measures, the females tend to have higher frequencies than males. And to look into different languages, Well, looking at this paper, the paper study showed that Mandarin speakers tend to have a higher frequency range as well as intensity range than other languages. In here, other languages include English, Swedish, and so on. And the reason for that is because Mandarin is a tonal language which allows greater flexibility of speech than other non-tonal language. Hence, we can kind of predict that the same could possibly apply to Cantonese, which was purely our own guess. Because no paper was found, unfortunately. And let's look into the dysphonia population. Vocal fold abnormalities, the following list of the vocal fold abnormalities possible, which are the possible etiology for dysphonia. And the first 1, 2, 3, 4, 5, 6 are the one that were included in our paper, the Cantonese population paper, which Victor will talk about. And the quasi-granulomas will be the Swedish population, in which Dr. Victor will talk about as well. So what's the characteristics of dysphonia? And here we do need to relate to what Eunice will talk about later on, which includes a lower pitch for dysphonic population, a hard glottal attack, a rigid melody or confined pitch range, hoarseness, breathiness, roughness, and aperiodic signal in severe dysphonic voice. So these characteristics will be once again revisited when Eunice talks about her part, which is very important. Now let's pass the time to Victor, which she will talk about the two papers, the Cantonese and the Swedish. Thank you.
So the first paper we are going to look at is the reliability of speaking and maximum voice range measures in screening for dysphonia for the Cantonese population by Robertson et al. In 2007. So the participants were 90 dysphonic Cantonese women with laryngeal pathologies and 35 Cantonese women with normal voices, which is the control group. So the laryngeal pathologies listed here. And the program used was sound wells, phoned 1.0, which is different from the traditional one, which showed in the video, the YouTube one. So the results showed that there is significant differences between the dysphonic group and the control group, which are this. So the dysphonic group showed a significant lower or smaller in highest frequency range, intensity range, and also in profile areas. And the dysphonic group also has significant higher in lowest frequency, maximum intensity, and minimum intensity. Okay? So the second paper we are going to look at is the voice and speech range profiles and voice handicap index for males, methodological issues and data, which is among the Swedish population by Helen in 2012. So the participants were 30 vocally healthy men with a mean age of 32 years old, and 4 Swedish male patients with contact granuloma. And the computer program used was also the PROM. And the results showed that the granuloma group, the G represent the granuloma patients, which G1, G2, G3, and G4. And then, so the results showed that there was significant, there was significantly lower or smaller in highest with granuloma patient in highest frequency. Lower highest frequency range, intensity range, and the profile areas, and significantly higher in minimal intensity. Yeah. So which are the three out of 4 of the granuloma patients show significantly different compared to the control group, especially for the G3, which the research showed that his or her VRP differ in upper and lower contour, which are more uneven, and which also affect the shape of the VRP compared to the control group. but G4 has no significant differences compared to the control group from the research. Okay, so then I will pass it on to Eunice to talk about the summary and limitation.
Now let's talk about the summary and limitations. For summary for diagnosis, VRP is used to review deficits over individuals' entire frequency and intensity range. As found in previous research, disordered population tends to have different frequency measures, different intensity measures, and different profile area compared with normal population, especially for higher maximum for intensity measures. Disordered population shows higher maximum intensity, with the maximum intensity being lower in the control group, as they are more conservative in higher intensity. But VRP is not recommended for differentiating between diagnoses, as it only measures frequency and intensity. For individual factors, in relation to what has been mentioned by Clara, it has also been found that disordered population's characteristics may affect VRP measurements in a variety of ways. First, the change in voice quality among patients may lead to higher loud phonation contour with higher maximum intensity and also an enlarged VRP area. Second, patients with breathy phonation shows 15 dB lower intensity than patients with non-breathy phonation. Third, trained voice increases voice intensity with different amount of jaw opening and different quality of vowel, whereas untrained voice increased intensity is naturally accompanied by increased frequency. Finally, there's no simple one-to-one relationship between normal voice and pathological voice, with no fundamental frequency found in severe dysphonic voice due to aperiodic signals. Despite its many advantages, VRP has its limitations. It's not only very time-consuming, it also provides no information on functional speech abilities, with no standardization on the elicitation of maximum phonation, task instructions, and the number of repeated trials. Therefore, we suggest using the speech range profile, SRPS, an alternative measurement. Unlike VRP, SRP uses connected speech rather than sustained phonation, and connected speech has been found to be better than sustained phonation due to the exceeded physiological vocal limits obtained from traditional VRP measures. Moreover, it defines the voice limits during the functional speech activities. And many previous research use readings from famous drama plays to obtain SRP, such as using the Cantonese passage, North Wind and the Sun, in the research of Ma and his colleagues in year 2007. Last but not least, as shared by Mrs. Kwan's talk yesterday, speech measurements can be used to review differences in fundamental frequency, frequency range, and intensity range between Parkinson's disease patients with dysprosody and normal population. That's the end of our presentation. Thank you. And here are our references. So, question time.
Sorry about that technical issue. I believe there's a bit of probably conversion issue about slides earlier on. But please still ask questions if you have any. Yes, please.
You say that it's a time-consuming exercise. So, how long usually the standard measurement to get the whole vocal range?
Normally,
30 minutes or normally?
Normally, according to literature, is around 30 minutes. And it was particularly mentioned that for screening purposes, is particularly time-consuming because you go through all the ranges, all the intensities, and especially if you do it manually, you calculate the log formula and so on. But that's computerized program which you can use, and they
still need 30 minutes,
yeah.
even for computerized version.
Thank you, Group 5.
Thank you very much.
Now we have Group 4 presenting vowel space. 有乜 space 先 sorry stop 嘅？咩一開始嘅時候撳 space？
So, good morning everyone. We are group 4 and we will have the presentation focusing on the acoustic measures of vowel space. So these are the 3 research articles we selected. The first article is about using vowel space and other acoustic measures of vowels to identify one's dysarthria and the severity. And the second article is about using vowel space to measure the treatment efficacy of circumlaryngeal therapy in muscle tension dysphonia. And the third article is about measuring the vowel space of children speaking Cantonese aged 4 to 12. But first of all, what exactly is a vowel space area? Anyone knows the vowels at the 4 corners? The high front vowel is E, yes, and the low front vowel is yes, and the high back vowel and the low back is oh, very nice. This area is actually an acoustic index commonly used in clinical research to indirectly assess the normalcy of vowel articulation. And there are 2 common types of vowel space area. The first one is quadrilateral vowel space area, QVSA, which is the area within the irregular quadrilateral formed by F1 and F2 of the corner vowels E, A, R, and U. And the second one is triangular vowel space area, TVSA, which is formed by the F1 and F2 of the corner vowels E, A, and U. Vowel space area is sensitive to changes in articulatory function associated with specific speech disorders, and Roy and his colleagues suggested that QVSA is more likely to capture articulatory abnormality than a triangular VSA, because abnormality might be in only one vowel rather than in all vowels. But of course, there are also other ways to measure the vowel space area. And this is the formula we use to calculate vowel space area. We simply need to substitute all the F1 and F2 values of different vowels into the formula. Like this one means the F2 value of E, and this one means the F1 value of A. And the vowel formant elements are measured in Hertz. And now I'll introduce the characteristics of the 2 selected populations, dysarthria and muscle tension dysphonia. Dysarthria, according to Asha in 2007, is a motor speech disorder that results from impaired movement of the muscles used for speech production. And the vowel production in dysarthria is distorted regardless of the underlying neurological etiology. Because of articulatory undershoot, which is failure for vowels to reach the canonical formant frequencies, it results in reduced working vowel space. And the possible reasons for the vowel production deficit is reduced excursion and velocity of lingual, lip, and jaw movement. Vowel acoustics should reflect these characteristics, including centralization of formant frequencies, reduced vowel space area, abnormal formant frequencies for both high and front vowels. For muscle tension dysphonia, it is hypercontraction of both intrinsic and extrinsic laryngeal muscles. Remember, both intrinsic and extrinsic muscles in the areas like face, jaw, tongue, and neck. It is a kind of voice disorder associated with excessive muscle tension in laryngeal and perilaryngeal muscles. It might be associated with reduced vowel space area and distorted vowels. And the possible reasons for the vowel production deficit is tight glottic and supraglottic contraction and compression, as well as incomplete glottic closure. And now Phyllis will talk about how we can use vowel space area to diagnose dysarthria.
Thank you, Paul. So now I'll talk about the first article, which is on the vowel spaces of dysarthria patients. So the purpose of this study is to determine which vowel matrix can distinguish healthy speech from dysarthric speech, and to determine the severity and the subtype of dysarthria if one has, like ataxic or hypokinetic. So there are lots of methods to measuring the vowel acoustics so as to capture vowel production deficits. in dysarthria patients, but it is unclear that which of them is capable of diagnosing one with dysarthria. So the traditional measure one is to use the vowel space area, but the visibility of VSA in the discrimination of dysarthric vowels are inconsistent in different researchers. Like one of them said that VSA is not reduced in patients with Parkinson's disease, but another stated that VSA was significantly reduced for the PD patients, showing that VSA may be not that accurate. So because of this, and there are also other proposed measures to try to measure the centralization of formal frequencies. So what exactly can be seen in the VSA of dysarthric patients? So this is an example from Roos et al., which is comparing between a shrink vowel space here and a normal vowel space here. And centralization of formal frequency can also be seen here. So the study has included a lot of acoustic measures measuring the vowel space to test their reliability on diagnosing dysarthria. So all the vowel matrix here are actually being tested in the study. So we would like to address the QE assay and front dispersion in this study here. So what is front vowel dispersion? So front vowel dispersion is actually measuring the distance between these 5 front vowels of the overall distance of F1 and F2 between them. And this is because we can see tongue height errors in dysarthria, which is implicating that they have tighter articulatory working space of the front vowels. So measuring the distance between the front vowels can help to capture this deficit. So let's go to the method part. The study collected speech examples from 57 speakers. 45 of them are dysarthric and 12 of them are health control group. For each subtype, the number of speakers are similar. And the study analyzed 36 phrases, and each vowel is produced for 4 times. The F1 and F2 are measured at different times of the vowel production to ensure best accuracy. So let's look at the data. And for QE assay and front dispersion, we actually having a very small p-value, which is indicating that both of them are very significant. And let's look at the mean as well. The mean in dysarthric patients are much smaller than that of the healthy control, as you can see here. So this is actually showing that VSA is indeed shrinked in dysarthria patients. And the classification accuracy of both QVSA and front dispersion are more than 80%, and they are the 2 most accurate ones in the study. However, for the accuracy of identifying the severity, the 2 measures perform differently. Front dispersion is more sensitive in identifying mild and severe patients, and QVSA is more sensitive on identifying moderately severe patients. So the result for the measurement of the dysarthria subtype, the data shows that average F2 slope and dynamic F2 slope are the most reliable indicator of dysarthria subtypes, but the data accuracy is not significant, which is lower than 50%. So the results are demonstrating that dysarthria patients with different underlying etiologies can be differentiated from healthy control speakers by various methods to measure the vowel space. And we can also see that vowel centralization is actually found in dysarthric speech. And front vowel dispersion in QVSA has actually more than 80% of accuracy in diagnosing dysarthria, but the accuracy of severity rating is different. So it is suggested that they should be used in tandem to ensure best results. However, using the vowel matrix to classify the subtypes of dysarthria is not that reliable. So to evaluate, 10% of all vowel tokens will be measured by same and different judges to determine the inter- and intra-rater reliability. And most of the p-values are highly significant in the study, showing great credibility of the data. But the acoustic rating for dysarthric severity is quite subjective in this study, and the sample size for each severity level is not well balanced. So we think that this article is a good one to try to determine whether VSA can be used to diagnose the dysarthric patients or not, but the part of measuring the severity is not that reliable, and further research on this should be conducted. So now I'll pass on the Alpha to talk about the dysphonia part.
For this article, the purpose of this study is to examine the changes of valve articulation among patients with muscle tension dysphonia following the manual circumlaryngeal therapy. Okay, do you guys pay attention? Still remember? Both? You are so smart. Yay! Let's see. The MC therapy is the laryngeal repositioning through brief displacement or by resisting laryngeal elevation to stimulate the improved voice. And the patient was taught to rely on sensory feedback to maintain the improved laryngeal posturing and muscle tension. And the circumlaryngeal massage was often applied. Let's watch a video clip on the procedure of the laryngeal muscle for patients with dysphonia.
So what you do is you take your thumb and middle finger and you find the hyoid bone and you kind of encircle it with those two fingers and you work your way back until you can feel the notches, and then you just kind of go in a circular motion on those to massage that area. Next, you would do the tips of the hyoid bone in the same motion.
Okay, you may finish the video yourself if you're interested. The participants in this study were more than 100 women diagnosed with MTD who received the MC therapy and PM post treatment. The speakers read out aloud the second and third sentences from the rainbow massage and the rainbow passage, and the sentences were say rainbow. And this is the sample of rainbow passage. And the highlights are the targets, which involve the vowels used in the articulating acoustic analysis. You can see this is the target vowels. And PM post-treatment recordings of the participants were analyzed using two vowel acoustic measure, VSA, and the vowel articulation index. But here our focus is the vowel space area. So I will just talk about the VSA. And the result of the acoustic measure were constructed using F1, F2 of the 4-point vowels extracted from 8 words in the rainbow passage that I have mentioned. And results show the increase in QESA of MTD patients by 13% after the MC treatment. And the t-test reveals statistically significant increase in QESA of MTD patient PM post-MC treatment, suggesting successful treatment of MTD is associated with vowel space expansion. And actually, you can see most of the F1 and F2 of the vowels has a reduced mean post-treatment. Although MTD is considered a voice disorder, and MC treatment did not focus on articulation, but improvement in articulatory acoustic were observed. The study stated that the increase in VSA may reflect improved vowel tract dynamics and articulatory movement during vowel production, but what aspect of the vowel articulation seemed unclear, and it is possible that the change in vowel space following treatment was due to the biological linkages between these muscles. And this is commonly observed symptoms of abnormal laryngeal muscle tension of MTD patient, like the tight glottic and supraglottic contraction and compression. And it has been deduced that some lowering of the F1, F2 that I have mentioned following the treatment could be related to a more normal pattern of vocal fold closure with reduced trachea coupling and reduced supraglottic compression. And this study seemed to show articulated changes of MPD patient after treatment in the result. However, as displayed in the result, only 3 single vowel changes changed significantly pre to post treatment, and also the effect size for the QESA is very small. Okay, this finding is just based on paragraph segment, and since different speech styles and different phonetic environment can affect the acoustic measure of the vowels, therefore it may affect the result. And in this study, only women participants were recruited. And also, additional studies are needed to assess the nature of MTD on the effect of vowels, and the VSA cannot be effectively used to assess the change in performance in patients with MTD who receive NCT because of the limitation that I have mentioned. Okay, I will now pass over to Jessica.
Thank you, Alva. Now I'll talk about vowel space area and Cantonese-speaking population. And this article is to investigate the developmental change in formal frequency of these vowels in children from age 4 to 12. And the cross-sectional approach is adopted for 5 children times 2 genders times 9 age groups. And my question is, can you think of some possible words for these 2 monosyllables?
No.
Let me tell you. And for example, for yi, you may think of yi or 1, 2, 3 And in here, in this test, and number 2 is used, and for ha, you may think of summer, 夏天, dai ha, or like this here, ha. And the other 3 words used are se, fu, and or. They are all in mid-level tone, and to rule out the pitch effect of foreign frequencies. Oh, sorry. And for a result, you can see that both male and female have very similar change. When age increase, F1 and F2 decrease, and the vowel space reduce, and the position shift towards the origin of the F1, F2 plane. And this result is similar to the findings in English-speaking children. However, one difference is that the foreign frequency between Cantonese children started to emerge at 7 years of age instead of 3 to 5 for English-speaking children. And the clinical implication is that the result can potentially serve as a reference to compare with the vowel space for children with speech sound disorder. However, when using this measurement, we have to be aware that the emergence of gender starts at age 7 for Cantonese-speaking children. To evaluate as age increase, the vowel space of children decrease. This can be explained by lengthening of vocal tract and decrease in formal frequency. So this study is confirming with this theory. However, the study has a relatively small sample size, so further studies are needed. Our hypothesis is that this reference can serve as a reference to child deciphered speech in Cantonese. In the studies, vowel space of 23 4-year-old cerebral palsy children speaking English were measured, and there are in 3 groups. The group with no speech motor involvement, the group with speech motor involvement and typically developing language and or cognitive ability, and those whose ability is already impaired. And you can see that the vowel space area of NSMI group are much larger than those of SMI-LCT group for the same age, indicate that the several patients have a relatively smaller VSA, not only in adults but also in children. Compared with the Cantonese data, VSA of children without dysphagia in 2 studies are similar, both around 1,000 K. So, our hypothesis is that the VSA for English non-deciphered children with CP and Cantonese normal children are similar, so the VSA for English deciphered children and Cantonese deciphered children might also be similar. If this is true, then the data in Cantonese-speaking children vowel space can be used as a norm to diagnose if one has dysphagia or not. However, as I mentioned, gender should be considered and further studies are needed. To conclude, for dysphagic diagnosis, mean dispersion of fun vowel space is the most reliable indicator, and QVSA comes next. However, VSA is not a sensitive measure to assess the treatment efficacy of MC therapy for muscle tension dystonia. And for Cantonese part, Cantonese norm of VSA can serve as a reference for diagnosis of dysphagia, but because of different F0, individual vowel space are not exactly the same, so the data can only serve as a reference. Thank you. And this is our reference.
Okay, let's break for 10 minutes. Come back in 5
Thank you.
嘅就先嚟。哥哥，我唔知啊，唔知啊，我要去開個 test。我頭先嗰個就係我講咗好多次㗎啦，我真係講咗好多次㗎啦，多過廿次，都係唔同嘅時段係都係有一兩次啦。可能有用嘅，係會用嘅，係啦，應該會有用嘅。咁暫時一行一張。
所以你又話出嚟嘅，跟住唔知去咗邊嘅？有啊，呢行一定出
打2零就打 Enter。你一開始嘅時候就點一啲綠色撳space bar，跟住點一啲你嘅 power。
嚟㗎。
Okay, let's have group 2 common transition.
Hello, we are group 2 and this is Winnie, this is Michelle, Cherry, and I'm Melanie, and our topic today is formant transitions. So, formant transition refers to the rapid change in frequency of a formant for a vowel immediately before or after a consonant or between vowels. It changes in resonating cavities of the vocal tract, and the manner of articulation of a consonant gives information on the F1 transition, whereas the F2 and F3 transition, it is the places of articulation that matters. As the frequency to which each transition or consonant are consistent for given across different vowels consonant contexts, formant transitions can act as important cues, perceptual cues to phonetic contrast. These frequencies are called the consonant's locus frequencies, which bilabial stops have locus frequencies of 600 to 800 Hertz, alveolar stops at 1,800 Hertz, and velar stops at 1,300 Hertz and 3,000 Hertz, respectively. In formant transitions in stop consonants, F1 always rises as stop consonants involve obstructions being made in the vocal tract, and direction of F2 and F3 formant transitions depend on the particular construction producing the stop, that is lips, tip, tongue tip, and tongue body. And it is important to understand that the exact shape of the formant transitions will vary according to the neighboring vowel. And let's take these two examples and focus on the voice stop, like this one here. This is aba first. Yep, this is aba. So the formant transition occurs with the start of vowel following a voice stop. That both F1 here and F2 here, as you can see, are at a rising transition in this case. As you can see in this circle here, with the voiced consonant, you can see a voicing bar during the closure in the spectrogram. As the mouth is still closed, the weak striations here are at the low end of the frequency. However, at the moment the stop constriction is released, the resonances of the vocal tract filter change very quickly. Now compare this spectrogram to this spectrogram here, which is apa. As you can see, there's a noise burst here at this area, which weakened the formant transition as the movement of the tips of your lips and tongue take place during the burst, unlike this voice stop. And let's look at these two examples. Now, can you guess which one is ata, as raised T, ata, and which one is ada? The left one will be ata, yes, the right one will be ada. Exactly. The formant transition of consonant D to the da, to a is very clear here. As you can see, the F1 is the F1 is rising and F2 is falling. But with the influence of aspiration, the transition is really unclear in the ata spectrogram. And the same thing happens to aka and aga. As you can see, the F1 of g is rising after the burst, and the F2 is rather level. And as you can see in aka, the rising of the F1 is already unclear. And in the formant transition of diphthongs, the most relevant acoustic characteristics of diphthongs production is the increase or decrease of second formant frequencies from the beginning to the end of the diphthongs. And this is related to the vowel space of different vowels. Acoustically, we can hear the change in articulation as a movement in the formant frequencies caused by the changing frequency response of the vocal tract tube. As our articulators move in a smoother manner, that we are only rising or lowering our tongue, the formant transition is also smoother in compared to formant transitions of a consonant stop. And now I'll pass the time to Michelle to talk about our first
article about stuttering and its relation to the form and transition of stuttering people. Oh no, hearing loss people.
So first, let me give you some idea of the speech characteristics of hearing impaired people. It may include errors in consonant and vowels, and also errors of rhythm. Examples of consonant and vowel errors include substitution, misarticulation, nasalization, and so on. Then we'll look into a research paper that investigated the form and transition in people with hearing loss. The subjects of the research includes 6 adolescents with normal hearing and another 6 hearing impaired adolescents. The severity of a hearing impaired group range from moderately severe to profound, and their speech intelligibility varies. The 2 groups are tested by reading 20 common CV or CVC monosyllabic words, including 4 word types. Then I'll show you some spectrograms. These are the form and transition to the vowel E for the normal hearing group. Despite some variation among the group in locus values and the vowel target F2 values, a general trend can be observed. The F2 frequency increases from bilabial stop or alveolar stop into hyphen vowel E. The average frequency change of F2 for D is 320 Hz, and that for B is 705 Hz. Then we'll move on to the form transition to U. In Do, the F2 frequency decreases from alveolar stop to the high back vowel U. We can see some variation in slope and frequency at 120 milliseconds. That means the endpoint of the blue line. In FO and JB, that's the top right hand corner, the 2 graphs on the top right hand corners. The slope is significantly flatter. As mentioned in the journal, when alveolar consonant is added to U, it would create an extensive transition, which is referred as an initial glide of a diphthong U. So as we see in the graph of FO and JB, the endpoint of the blue line is significantly higher than the red, indicated that the F2 of Do is still at an appropriate frequency position for E, hasn't reached U yet, so which the position of U should be lower. And for the rest of the subjects, the F2 value of U is nearly reached but not yet entirely reached. And for Fu, the F2 transition is very light. Now look at the graphs for hearing impaired group. It is quite obvious that the lines are much closer to each other compared to the previous group with normal hearing. There are much less separation in F2 target values of E than normal, especially in target 2, 3, and 5. According to Angela C. et al., vowel fragments of deaf adolescents tend to be more centralized and therefore less distinctive. Apart from that, the duration of F2 transition is inconsistent. In subject 3 and 5, the duration of transition is relatively short. The target F2 value is already reached at about 40 milliseconds. The average frequency range of F2 for D is 160 Hz, and that for B is 320 Hz. Similar findings is observed in the transition to the vowel U. Again, the F2 value are less separated than normal, and the duration of transition is inconsistent. Something special in the hearing loss group is that subject 6 frequency separation of target F2 values and the extent of frequency change nearly resemble normal. To sum up, the hearing impaired people has reduced frequency range, as we see the lines are less separated than the normal group, and the F2 target value of certain vowels is different from the normal group. In this research, the F2 target value of E is lower, and the formal transition is diminished. This is probably because the hearing impaired people may adopt
production strategies that are different from people with normal hearing. All this added together will reduce the overall intelligibility of their speech. For the evaluation of the research paper that we used, firstly, it might be quite outdated as it was published in 1967. And there are lack of information in the reason for selecting the targets, and only 4 targets are selected. Whether the subjects are aided with hearing aids were not mentioned as well, and the subjects participated in the research is quite limited. There are only 6 subjects in each group, so the validity of the research is low. And we think that measurement of second foreman transition actually cannot be determined as a diagnostic tool of hearing loss, because measuring the foreman transition could only reflect the performance of speech production. Now I'll pass the time to Cherry.
Thank you, Michelle. Another disorder group we would like to talk about is dysarthria. It is a motor speech disorder results from impaired movement of the muscles used for speech production. The type and severity of dysarthria depend on which area of the nervous system is affected. So these are some general speech characteristics of dysarthria, for example, slow rate of speech or rapid rate of speech. Here's a study examining F2 slope of diphthongs in relation to severity of dysarthria. The study had recruited 20 participants from PD and stroke group respectively due to the difference in speaking rate. For PD, majority reports suggests normal or faster than normal rates, whereas typically slower than normal for stroke patients. Besides the 40 male speakers with dysarthria, 5 male speakers were also included as control. So they were asked to repeat coat, hail, shoot, sigh, and roll and wax for 10 times. And these words were selected because their vocalic nuclei require relatively extensive changes in vocal tract. 8 tokens were then taken for analysis, and they were asked to recite 3 sentences for speech intelligibility ratings by 3 graduate students. Program TF32 was then used to derive the F2 slope by looking into the transition extent and duration of diphthongs. Then statistical analysis was then performed to make comparisons of the results. This is the table illustrating the statistical data of each word. In the middle part of the table, the middle part is the transition duration, and this is the time between the transition onset and offset. For the right-hand side part is the transition extent. It's the frequency change between the transition onset and offset. Using these data, you can use them to derive the transition, the F2 slope using the formula transition extent divided by transition duration. Now let's do an activity and draw the F2 slope together for PD and normal group. There's a plotting graph previously distributed to each group. And for the x-axis is the transition duration, which is the difference between the transition offset and onset. And for the y-axis, what is the y-axis? This is a spectrogram, so what is the y-axis? Frequency, right? Frequency. So now, taking the example here, the word hail, the diphthong is highlighted in red. It is the sound A and E. So we would like to take the data and then draw the F2 slope together. Maybe you can have 1 minute to draw it first. I'll give you 1 minute.
Remember there is a transition onset as well. So you remember just now Cherry said about the extent is about the time, the duration, the frequency between the onset and offset. Okay?
The cross is the transition onset time. Remember, it's the difference. So you're not just
yeah, you try to do it.
yeah. 30 seconds left.
X-axis, Y-axis. Just the PD group.
10 seconds left.
Okay, stop. No more time left. Anyone derive this F2 slope already? So the part in green is the PD group. So the duration is 221.69. So
Here's the difference. The difference is 221 milliseconds. So you need to count from 100. You add 221 from 100 along the x-axis, and then for the frequency, the onset transition is 1,500, and the data is 884. So you need to add 884 from 1,509 up along the x-axis.
So when you're joining the two dots, this will give you the F2 slope of the PD group. So can you notice the difference between the slopes of the former transition? Yes. What's the difference? Clara, what's the difference? Between the yellow and the green. Yeah, it's steeper. Normal is steeper. So these are the comparisons. For normal speakers, the F2 slopes were greater, and they have the greatest transition extent across the words. And speakers with dysphoria reveal shallower F2 slopes due to longer vocabular nucleus duration. And surprisingly, the two groups, the stroke group and the PD group, have a similar shallow F2 slope despite of their different speaking rates. So here comes the evaluation part. Presumably the 6 words used require the most rapid and largest changes in vocal tract. However, some of the words are not sensitive to the dysphoria speech, resulting in similar slopes among the 3 groups. And there is a differential sensitivity of speech material to the dysphoria in people with multiple sclerosis, which is difficult to make generalization to other disorder groups. F2 slope is an indicator of a change in vocal tract, but cannot be considered as a sufficient acoustic measure to diagnose dysphoria. I'll pass it on to Winnie.
Okay, so I will talk about the Cantonese population in the South. Another way is the Dysphoria in Cantonese population. So from a recent research, about the development of a Cantonese dysphoria speech corpus, which conducted in 2015, it shows that English dysphoria speech has already investigated in several studies, acoustically and perceptually. But however, Cantonese one is still lacking. So you can see from the research in 2000, it's just about the perceptual phonological approach, phonetic approach, but it's not really publicly accessible. So consequently, when we want to see the dysphoria in Cantonese population with the formal transition, it is very hard to find the relevant journal. So therefore, our purpose is to investigate the English dysphoria speech in the stop consonant and hypothesize the Cantonese dysphoria speech in the stop consonant by using formal transition. So before we making the hypothesis, so yeah, we didn't expect that because anyway. So before making the hypothesis, so we did some research about it and aspiration and aspiration one. So you can see from the PD group, it's much flatter as well in both the aspirate and unaspirated consonant. And so for the voicing in stop consonant as well, we can find that in English. The study shows that the voicing in voiceless stop and voicing in voiceless stop. In English, it has both the voiced and voiceless consonant. But the interchange, however, in Cantonese, it does not have the voiced consonant. So is that possible to have the same result as this research? So therefore, we have made some 3 hypotheses for the third future study. The first one will be the flatter aptitude slope of the consonant vowel formants in producing in both aspiration and unaspirated consonant. We are here in December speaking Cantonese. And second, wait, I still have Cantonese speaker will be like this, have the voiceless stop to a voiceless stop and show a shorter one. And for the Cantonese speakers, it may no change because it may just have voiceless, so it just have a longer and shallow one in the formant transition. So that's the end of our presentation.
So no mouth deduction for overrun, right? Very good. Next group. We have 7 boys on 6 halves. Space bar 先至開個 PowerPoint show screen。Okay, let's start.
Our topic is stop closure interval and voice onset time. Stop closure interval or stop gap is the complete blockage of vocal threads at bilabial, alveolar, velar, or other position. Upon release, it creates energy bursts. In voiceless stops, the stop gap is complete silence. That means no acoustic energy at all. But in voiceless stops, we can see some no frequency voice bar here, indicating the vibration of vocal folds with some energy. Voice onset time, VOT, is the interval between the bursts and the onset of voicing. It can be negative in voiceless stops, 0 in voiceless and aspirated stops, or positive in voiceless aspirated stops. Here is one example. This voiceless stop has no pre-voicing, and also it has frication and aspiration noise, so the voicing of the vowel starts later, resulting in a positive VOT. We selected 3 journals, including diagnosis of Parkinson's disease with VOT, treatment outcome assessments in stuttering with stop closure interval, and the last one is the application of VOT in Cantonese-speaking populations with profound hearing loss. Many patients with Parkinson's disease have hypokinetic dysarthria, which is featured by breathiness, weak voice, monopitch, monolaulus, imprecise articulation, and fast speech rates. Here we can hear some example.
I'm waiting because I don't want them to see my new condition.
Okay.
Of course, and I don't want them to pity me.
Yeah. Why are we using VOT for Parkinson's disease? The assumption is that decreased dopamine level directly causes motor deficits, including muscle rigidity, reduced movement range, and slowness. Since phonation and articulation is under motor control, they are greatly affected and cause abnormal speech. Acoustically, it can change the voice onset time because it is an index of time control between the lower laryngeal and upper articulatory movement. In this research, 12 Indian patients with Parkinson's disease and 12 normal adults participated. The patients were asked not to take any drugs before testing, so the medication effect was removed to ensure the patients were at off state and showing original PD symptoms. And the participants read an English story. The productions of B, D, G were analyzed with plot. Then we look at the results. The results firstly showed both groups had positive VOT in voice stops. Why it is positive but not negative? It may be because the devoicing is a common feature in Indian speaking English. Secondly, you can see the PD group have longer, more positive VOT than the control group. And as shown in this table, the difference percentage is large enough to suggest significant variations between these two groups. Therefore, VOT can help differentiating people with or without PD. In detailed evaluation, in this experiment, factors like age, gender, testing procedures, softwares, etc. are kept constant as controlled variables. So there was only one independent variable, with or without Parkinson's disease. It completely contributed to the dependence variable, longer or shorter VOT. Therefore, the one-to-one cause and effect relationship was very clear. PD symptoms cause longer VOT. However, we can only say this result is valid within this research. The reason is beyond this research, there are different studies showing different results. Some show longer VOT because of the incoordination of the laryngeal and articulatory muscles, and some show shorter VOT because of the accelerated speech rate in PD patients. And all these explanations are very possible. So far, there have been no shared conclusions on whether PD patients have longer or shorter VOT. In this study, the author did not propose any strong evidences or illustrations to support its own argument, longer VOT in PD. Therefore, the effectiveness of using VOT to help diagnosing Parkinson's disease is still unknown. Regarding the varied results in different studies, some researchers proposed it was speech rates affecting VOT. So that fast speech rates in PD patients actually affects the accuracy of VOT measurements. It is also a shortcoming of this research because there were no considerations of speech rate. One solution is using VOT ratio instead of conventional VOT, because this formula can eliminate the effect of speech rates on VOT. Okay, I will pass the time to Shandy.
Okay, thank you, sir, for the analysis. So for the journal that we talk about stopgap is acoustic duration changes associated with two types of treatment for children stutter, which was written in the year 2000, and it is related to stopgap and stuttering. So let's go through the characteristics of stuttering first. So for speech characteristics of stuttering, the patients may produce sound or syllable repetitions, prolongations, and blocks when they speak. And there are other kinds of behaviors, features, such as blinks, facial grimacing, changes in pitch or loudness, and associated with physical tension or struggle, and negative reaction or frustration. So that's a quick revision about something that we have learned in the previous semester. So can you tell, so question time. So can you tell me what is it in 1, 2, and 3? Any idea is about there's something that we are talking about? So you have choice. So number 1 is burst, number 2 is stopgap, and another one is VOT. Yeah, so good, correct. So how about number 2? Yes, correct. What about number 3? Oh, it's also stopgap. You're all very good already. Okay, so sorry. So go to the next slide. So the previous study mentioning that the severe stutters have longer stopgaps, and as an acoustic measurement, stopgap helps to give a unified understanding of speech. So it supports the idea that stopgap was useful in distinguishing the severe stutters and non-stutters, and stopgap had been used as an acoustic signal that helps to understand speech. So the purpose of this research article is to examine the effects of speech motor training, or in short form SMT, on young children measured by 4 temporal acoustic durations, including stopgap. And another purpose is to compare the treatment outcome with extended length of utterance, which does not directly incorporate speech motor control training. So both of them are stuttering treatments, but the difference is that ELU doesn't involve any speech motor control training. So let's have a very quick look on these two treatments. So for SMT, it's a history of over 20 years, and the purpose is to improve speech motor production. And in this treatment, child repeats the non-meaningful syllable sequence as displayed by the gradation, and the child gradually increases speech rate as the treatment program proceeds. And reinforcement of target speech behavior will be given. And for ELU and other stuttering treatment, and based on the response contingent stimulation and progressively longer or more difficult speaking tasks. So it started from monosyllable to multi-syllable utterances, and it trains the patients to speak from short monologues to longer monologues, and reinforcement and punishment will be given in different situations. So here's a background of the research. So for the goals of the research is to examine the effect of these two treatments in the reductions in stuttering frequency by measuring the 4 temporal aspects and stuttering frequency. So the participants, so for each group there are 12 participants will participate. So 6 students will be selected, 6 patients will be selected, and then another 6 will be normal children as reference. So the recordings will be recorded according to these syllables, and they use the method of ANOVA in the analysis. So let's take a look at the results. We can see that very clearly. So the red line represents the results of SMT, and the blue line represents the results of ELU. So for SMT, we can see that it has a significant reduction after the treatment in the stopgap duration from 130.7 drops to 93.6. But for ELU, you can see it from the blue line, there's almost no change, only 0.1 very slight change in the stopgap duration. So you can see that there's a big difference in the changes in the reduction of stopgap. But the result is very interesting. As you can see that SMT has a big reduction in the duration of stopgap. But for the reduction in stuttering rate, you can see that it's a big difference. You can see that for the reduction for SMT, there's only a reduction of 36.5%. But for ELU, it has a much higher reduction in stuttering. And the result tells us that it has a greater treatment outcome. So you can see that it's very interesting, right? Thank you. Okay, so for the other measure of study, and for SMT, so you can see that there's a big reduction in stopgap, but for the reduction in stuttering, it only yields a 36.5%. So the reasons accounts for it is that so they're mechanical drills. So the patients will practice speech more. It becomes a more automatic mode and more accurate tempo control. It will have a more accurate tempo control, and it becomes so the result in a decrease in stopgap duration. And there's no cognitive processing of motor control. It's hard to generalize across the context. But for ELU, you can see that there's almost no change, and 0% in the change in the stopgap duration. But the reduction in stuttering, you can see that there's a big decrease in stuttering rate, which is 63.5. So it shows that ELU is a more effective treatment outcome. So our analysis is that as a measurement of the treatment outcome, the stopgap duration can be applied to motor drilling programs only, but not to all the stuttering interventions. So for the final evaluation of this part, so there are some other studies also suggest there is no difference in stopgap in stop closure interval, which is stopgap, between stutterers and normal people, and the stop closure interval is not a significant measure for motor incorporation of stuttering. So this supports the idea that the measure of a duration of a section of speech can only provide very limited information about the speaker's coordination or relative timing of movement in the system. So thus more research should be done on the measurement of the effectiveness on stuttering treatment, apart from measuring the temporal aspects of speech. So I'll pass on to Kenneth to talk about the Cantonese part.
Thank you, and now we'll see how VOT is used to identify the speech characteristics in Cantonese adolescents with profound hearing impairment. So before going into the paper analysis, let's have a quick recap of the aspiration feature in Cantonese. It is a phonemically contrastive feature which only takes place at the syllable onset position, and sounds with the aspiration feature are produced at bilabial, alveolar, or velar in plosive or affricate manner of articulation. And typical examples will be the PTK sounds, and the paper I'm going to talk about to share with you is we'll use the typical PTK sounds as the measurement. And aspirations occurs after the articulatory release and before the first glottal pulse, and it can be used as a cue perceiving as aspiration contrast. So question time, when comparing with the unaspirated stops, what will be the VOT aspirated stops? longer, shorter, or no change. Yes. So the aspirated stops are having longer VOT. And in the journal article, it aims to examine the characteristics of aspirated and unaspirated word production produced by 10 adolescents with profound hearing loss and 10 peers with normal hearing, and see if aspiration's feature is a cue to distinguish the aspirated and unaspirated stops. And for the inclusion criteria, the selected candidates with profound hearing loss were those PTA score at the beta year was equal to or more than 90 dB loss at 1K and 2K Hz frequency, which is regarded as two important speech frequencies. And both groups were required to pronounce 15 minimal pairs of monosyllabic words with varying initial stops, vowels, and tones. And those words were randomly presented on cards, and the speech production were recorded via ANOVA. And there are two measurements in the study. One is the acoustic measure about the VOT in initial stops. Another one is a perceptual identification that all speech productions produced by both target and control group were identified by 10 Hong Kong Youth Speech Therapy students. And the listeners had to select the perceived sounds by pressing one of the 9 buttons available on the computer program. And for the results of the VOT production, there was no significant place articulation effects found among the two groups, and a similar VOT was found for their unaspirated stops. It was around 10 to 20 something milliseconds. However, the VOT for the aspirated stops produced by the target group was significantly shorter than the normal adolescents. We can see that the normal people produced the aspirated stops within 80 to 120 milliseconds, but the VOT of both aspirated and unaspirated stops produced by the target group was under 30 milliseconds. For the identification task, listeners were able to identify 97 to 98% of speech produced by the control group, and all were perceived as stops. However, only 29% of speech from the target group had been correctly identified. 36% of the incorrect ones still perceived as stops. The others were either perceived as initial deletion or non-stop consonants. And for the above two measurements, we discover a linkage between the two. That from the VOT production of the control group, we can see that there is a significant difference in the VOT between aspirated and unaspirated stops, and then it correlates with a high accuracy rate of the correct identification. While for the target group, they did not have such VOT differentiation among aspirated and unaspirated stops, and the words were poorly identified by the listeners. And such findings suggest that the larger the difference in VOT between aspirated and unaspirated stops, the higher the tendency of having a correct word identification. It in turn deduces that the VOT is a reliable cue to discriminate aspirated stops from the unaspirated ones. And it also explains the reason for low accuracy in target group production, because their intended aspirated stops were perceived as de-aspirated. And the study explains such de-aspiration occurs in target groups with profound hearing loss was due to their hearing challenges. The production of aspiration requires our vocal folds to flexibly and quickly open and close so that a rapid airflow can be passed through our vocal folds. And because aspirations is regarded as the high-frequency noise, having difficulty in hearing the high frequencies, they have a similar perceptions on both aspirated and unaspirated stops because they don't really hear the difference in between. And it greatly affects their ability of receiving a precise auditory feedback for monitoring their own speech production. As a result, it is hard for them to realize if they had modified their vocal folds wide enough so as to allow a rapid airflow passing through the abducting vocal folds during the aspiration production. So as the aspirations is likely to be found in their speech because aspirations is not the cue for them that will concern during the speech production. And it also affirms to previous findings that Cantonese speakers with severe hearing impairments is less likely to use aspiration noise as a cue to make aspiration contrast. And the paper also provide further implications that VOT may be used in speech rehab for the profound hearing impairment speakers, and as well as an objective measure to assess the production skills of aspiration contrast of the aspiration stops. And to evaluate the validity of the study, internally speaking, a valid framework has been constructed that the control variables like age, materials in the experiment are quite carefully kept constant. So the only factor that causing the difference in VOT was about the hearing ability. It in turn suggests that VOT in aspirated stop production was an effective measure discriminating the speech of the selected hearing impaired speaker from the normal speakers. Furthermore, the first author and teacher for the deaf have reanalyzed 10% of the samples, and the inter-intra reliability were up to 0.97 and 0.98 respectively. However, externally speaking, the small sampling pool in the study may not be able to represent the entire population with profound hearing loss, but just the selected speakers. And also, the VOT can be realized differently with the same word that is put in different linguistic contexts like phrase, sentence. So the study only record the VOT on the monosyllabic word may not truly reflect the actual performance of the speakers under the daily context. And to have many conclusion of our presentations, our first journal article states that found that the effectiveness of the VOT of the Parkinson's disease still remains unknown, and stop closure may be effective in accessing the stuttering treatment of outcomes in some SMS motor training programs, and VOT is a reliable cue to differentiate the aspirated stops production of the selected profound hearing loss at normal people. And that's the end of our presentation.
We deserve more applause because this is a 3-girl group, right?
Yes.
More applause for them. So we have another 3-girl group again. So this is group 1, a consonant So this is a 3-student group. We have the consonant vowel duration ratio and emphasis ratio. Group 1.
好慘
衫呢識控制晒。呢個 PowerPoint
Good morning, everyone. Our topic will be consonant vowel duration and amplitude ratio. And this is our groupmate, Kansas, Emily, and Janice. Sorry, technical issue. So consonant vowel duration is defined as the consonant duration relative to vowel duration. It is calculated by the consonant divided by the vowel. For example, let's assume the vowel and consonant duration is 10 milliseconds. If the consonant duration increases and the vowel duration remains unchanged, 10 milliseconds, the consonant vowel ratio will be 1.2. If the consonant duration remained unchanged and the vowel duration increases, the consonant vowel duration will be 0.8. Ratio smaller than 1 means that the consonant has a shorter duration than the vowel, whereas the ratio greater than 1 means the consonant has a longer duration than the vowel. Similarly, the consonant vowel amplitude ratio is defined as the consonant relative to amplitude is defined as the consonant relative to amplitude of the vowel. If ratio is smaller than 1, which means the consonant has lower amplitude than the vowel, whereas if ratio is greater than 1, which means the consonant has higher amplitude than the vowel. So before looking at how we diagnose stuttering and Parkinson's disease by using consonant vowel duration and amplitude ratio as an acoustic measure, we will start looking at the speech characteristics of both disorders first. One of the etiology of stuttering is the deactivation of left hemisphere sensory motor center and the overactivation of the sensory motor center in the right hemisphere, therefore creating a lack of sensory motor integration, which causing a disruption for the process time required to produce speech. The primary speech characteristics of stuttering are the repetition of word or parts of word or syllables, as well as the prolongation of speech sound. Speech may become completely stopped or blocked, and interjections such as or like can occur. This disfluency occurs more often in persons who stutter than they do in the general population. Some motor movements such as eye blinking and loss of eye contact may also associated with stuttering. On the other hand, Parkinson's disease is caused by the progressive impairment of neurons in substantia nigra, which decreasing the level of dopamine. A lack of dopamine results in abnormal nerve functioning, causing a loss in the ability to control body movement. For example, reduced range of movement and motion involving the lips, tongue, and jaw, which could reduce the level of speech characteristics, intelligibility. Some of the most permanent speech characteristics of hypokinetic dysarthria in Parkinson's disease are reduced vocal loudness and vocal decay, resulting in weak voice and accelerated rate. It will also notice hoarseness, especially breathiness in the voice, reduced stretch, mono-loudness, imprecise consonants, and repeated phonemes that make speech sound very slurred and mono-pitch. And now I will pass on to Kansas to talk about the duration ratio.
So this is the thing we use to illustrate the consonant vowel duration ratio is on stuttering. And this is the exact same journal Shanti has just talked about. And there are 12 children who stutter and who don't participate in the study. Children who stutter were assigned to either to receive the SMT speech motor training or ELU extended length of utterance. One thing that I would like to make clear is that we're not evaluating whether the treatment are effective in treating stuttering. Instead, we're looking at how children with and without stuttering differ in terms of CV duration ratio. Instead, we're looking at how children with and without, hence we will only walk you through the treatment approach briefly. In the SMT, children were trained to imitate and repeat nonsense syllables, which are also known as tokens, in a stutter-free manner. Once the child has improved, we can make the task more demanding by changing the number of or the shape of the syllable, whether it is a CV, CVC, or VC. The ELU, on the other hand, adopts a non-imitative approach. Children were trained to self-elicit stutter-free utterance, starting from 1 word to 5-minute monologue. So here we have got 4 conditions, but we will only focus on the upper bit, the SMT ones, since the acoustic measure of the EMT group with the non-significant results. The study compared children with stutter and without stutter before and after receiving SMT by measuring the differences in vowel duration, consonant duration, and the CV duration ratio, as well as the frequency of stutter, which serve as a non-acoustic measures. The children in the SMT group were trained to repeat these 2 tokens, pop, 10 times 3 syllables per second, and type 10 times 3 syllables per second. These 2 are the nonsense syllables. And a computerized speech lab software was used, and 2 trained clinicians were recruited for judging the duration of the consonant and the vowel duration. They are with high intra-judge reliability, which means they judge their own judgment before. And inter-judge reliability, they're judging whether the other person did a great job in identifying the consonant and vowel duration. And repeated measures ANOVA was used for as our statistical model. And before the treatment, although there were some differences in consonant duration, 103.7 milliseconds for children with stuttering and 103.47 milliseconds for children without stuttering, the p-value suggested the difference was non-significant. Non-significant result was also found in the vowel duration, and hence the CV duration ratio was also non-significant. Which means if I say or in a normal manner, and if I stutter to say or, that or in a normal manner and that or in a stutter manner is actually the same in terms of the duration. But after the treatment, a significant p-value was found in CV duration ratio. If we take a look on the consonant duration and vowel duration, the consonant duration was non-significant, indicating that the change in CV duration ratio is actually contributed by longer vowel duration. The duration has increased from 96.9 to 164.5 milliseconds, and resulting in a smaller CV duration ratio. So if we only rely on the pre-treatment CV duration ratio, it cannot give any information on telling whether a person suffers from stuttering or not, because if we look at the plot on the right side, this is the Cantonese part recorded by us. The duration of consonant and the vowel are nearly the same in people with stuttering and those without. So based on PRAC, any other stuttering information that may have speculating that a person may suffer from stuttering, any ideas? Because, for example, that or in a normal bit and the or in the stuttering people, they're actually the same. So looking at the part, we can't identify who is stuttering and who is not. So any other information? Yeah. Any idea?
Stop
Cannot. It's, if I put this like or and yes, exactly. Yeah, the repetition of syllable consonant. Good job. Yeah. So we will rely on some waveform before the consonant and the vowel, like that bit. So after the treatment, smaller CV duration ratio was found. So how the practice should look like? The tips is longer vowel duration. Any idea? You can anyone come and help withdraw using a weapon? This is the pre-treatment consonant vowel duration. And the tips is longer vowel duration. So how does the practice look like after the treatment? Anyone? Okay. It seems to me you know how to do it. Yeah, this is the before treatment, the C, consonant duration, like pop. Yeah. This is post-treatment. This is the blue line is the pre-treatment. So the same. And this is the post-treatment. So we are lengthening the vowel duration. And this is the answer. This kind of longer vowel duration is actually a technique of prolonged speech, which may help increasing the speech intelligibility of people who stutter. And I'll pass the time to Emily to talk about the amplitude ratio.
Francis. So moving on to consonant-vowel amplitude ratio, we have picked a relatively new paper from Kim 2017 to illustrate how this concept is being applied to Parkinson's disease patients with dysarthria. As you all can see clearly from this diagram, the study recruited 9 healthy controls and 10 Parkinson's disease with mild to moderate dysarthria, which the severity was evaluated by 6 graduate students in SLP program. In addition, speech intelligibility, which simply defined as the degree which the listener would easily understand what the speaker said, was ranged from 4.2 to 6.8 among the Parkinson's disease patients. The study focused on production of fricatives, as they are challenging articulatory gestures requiring air to be forced through a narrow constriction for a relatively longer period, ranging between 80 milliseconds and 180 milliseconds. So all participants were required to repeat the 2 words, sigh and shy, 10 times in a row, which yield a total of 380 syllables production. The task requires the use of TF32 computation program, which is one of the most commonly used time-frequency analyzed software for speech sound. 3 acoustic measures were used to analyze the findings, including amplitude of fricative, amplitude of vowel, and differences in consonant and vowel amplitude. It is worth noting that they are using consonant-vowel amplitude ratio. They are not using consonant-vowel amplitude ratio. The research only focused on differences in amplitude between consonant and vowel. From this table, you can clearly see that the overall vowel requires a higher amplitude when compared to consonant fricative for both groups, but healthy control group had a significantly greater amplitude at 9.39 decibel in pronouncing the fricative and vowel, whilst the Parkinson's disease group was having a 7.55 decibels. Moreover, the differences between fricative and vowel amplitude was found smaller for both words, sigh and shy, in Parkinson's disease patients. Based on the original table of average individual syllable of fricative and vowel, we could calculate the consonant vowel amplitude. We could calculate the consonant vowel amplitude ratio using the formula of fricative divided by vowel. As all values are smaller than 1, this shows that the vowel's amplitude was stronger. More importantly, although the result may not be significant, it showed Parkinson's disease patient had a greater consonant vowel amplitude ratio than healthy control. For ease of illustration, we have created these 2 figures of the same word, sao. The difference in amplitude for Parkinson's disease group is the one on the left. So you can see there's an amplitude difference of 2 decibel. And the difference, in order to convert to the ratio, we have to divide 10 by 12. So similarly, for the healthy control group, the difference in amplitude is 8 decibel, and the consonant vowel amplitude ratio is therefore 0.6. Thus, the smaller the difference in amplitude, the greater the consonant vowel amplitude ratio. Since there is no paper on consonant vowel duration and amplitude ratio on Cantonese population, we try to hypothesize the acoustic features in Cantonese population. Cantonese has a unique tone feature when compared with English. So according to traditional impressionist tone classification, there are 6 phonological tones in Cantonese, including high level, high rising, mid-level, mid-low level, low rising, and low level, which I'm sure you're all familiarized with. So Kong in 1987 found of the 6 tones in Cantonese, the high-level tone and the low-level tone are the shortest in vowel duration, whereas high-level tone has the longest vowel duration. Taking this into account, A longer vowel due to high rising tone, which results to a smaller consonant vowel duration ratio, doesn't indicate that prolonged speech technique was used in dealing with stuttering. Therefore, it may be valid in using consonant vowel duration ratio as an acoustic measure in diagnosing and distinguishing people who stuttered in the Cantonese population. So before going through consonant vowel amplitude ratio, there's a question for all of you. So have a guess. So if it's a voiceless or a voiced consonant, what will be the effect on amplitude? Yeah, so voice, you got it right. Voice is louder in amplitude. So as you can see, the consonant vowel amplitude ratio would be a better, it is relatively easy to understand voiced consonant will exhibit a larger amplitude, whilst a voiceless consonant has a smaller amplitude. So as illustrated from the figure on the left, it represents the Cantonese consonant vowel of sa, which is the voiceless example here, and the figure on the right shows the English voice consonant vowel. Since consonant has no voicing, it is hypothesized that both the consonants and the vowel a will have a relatively lower amplitude than the consonant ch and vowel a. If we calculate the consonant vowel amplitude ratio for both words, they will both yield the same ratio, which is 0.5. This example illustrates that consonant vowel amplitude ratio might have little value in using consonant vowel amplitude ratio as a diagnostic measure, since Cantonese are all voiceless, and that even if Cantonese consists of voiced consonants, this may not yield significant difference in consonant vowel amplitude ratio. Therefore, it may be useful to look into the absolute amplitude value instead. So now I'll pass the time to Janice.
So in the study of Burin and in the study of 1990, they found that increase in the amplitude of consonant doesn't affect the overall speech intelligibility, so vowel may play a role in speech intelligibility, as previous study focused on vowel amplitude instead of consonant vowel amplitude ratio. That's why it makes us so difficult to find a relevant or research journal on consonant vowel duration. However, Orr et al. In 2010 found that consonant amplitude may also play a role in speech intelligibility. Therefore, further studies should focus more on consonant vowel amplitude ratio rather than just focusing on the vowel amplitude. So to conclude, by just looking at consonant vowel duration and amplitude ratio cannot reveal whether a person is suffering from stuttering or Parkinson's disease. It should be diagnosed along with other acoustic measures such as VOT and Foreman transition. So this is our presentation. So thank you.
Thank you, everyone. Our last topic is on spectral moments. Please welcome group 8.
Hello everyone, today we are going to give a presentation on topic spectral moment, and these are groupmates Sandra, Kemi, and Nico. I'm Jay. And first of all, I'm going to introduce the production of the fricative and the definition of spectral moment, so you have a clear idea about our presentation topic at the beginning. And first of all, for the production of the fricative, the air goes through the narrow construction formed somewhere in our focal tract. It shapes the source spectrum into front and back cavity, which create a turbulent flow between the two sound sources and generates friction energy. And it is different from the foul. The air goes through one sound source only. And spectral moment actually is one of these four measurements of fricatives, together with the spectral peak, the dynamic range, and fricative duration. It makes the measurement of fricative become more precise, but the other three measurements are not our focus today. I'm not going to talk about that. And for the spectral moment, is this distribution familiar to you? No. It is the normal distribution. Spectral moment actually are similar to the idea of the normal distribution curve, and the spectral moment is a distribution of the numbers to describe the shape of a curve, as the same as the normal distribution. It has a mean, variance, skewness, curves. It doesn't matter you don't know all these words mean. I'm going to explain them in the following. One thing really important to keep in mind is that those four spectral moments represent the shape characteristic of an acoustic spectrum, but we've got different names in acoustic language. Mean, we call the mean the first spectral moment, variance the second spectral moment, and skewness the third spectral moment. And we call the curves the fourth spectral moment in acoustics. And for the first spectral moment, it is the mean of all numbers in the distribution. For the second spectral moment is the variance, which is about how much those numbers are dispersed around the mean. And imagine that is a line in the center of this bell shape, and the number are dispersed about the mean. Variance is actually a variance to describe how those numbers are dispersed around the mean. So pay attention to the peak in green. It is narrower than the red one. The energy bunched up in the center. In other words, it is less dispersed from the mean, and it has a lower value of variance. On the contrary, take a look at the curve in red, and it is relatively flat. So the energy spread across a wider range. It has a higher value of the variance. And for the third spectral moment, remember, it is really important to always keep in mind that spectral moment represents the shape characteristic of an acoustic spectrum, and skewness is talking about the degree of tilt of the distribution to the right or left of the center. And for the positive skewness, it is the majority of sound energy are bunched in the left-hand side, which is the low frequency. For the negative skewness, the majority of sound energy are bunched to the right-hand side, which is the high frequency. And for the fourth spectrum, kurtosis, that is the extent to which the distribution is peak or flat. The curve in green is the positive kurtosis. It's the distribution with a more pronounced peak than the normal, than the blue curve. And the negative kurtosis is the distribution with a shallow peak than the normal. So Nico is going to introduce how to generate spectral moment with parts and show you some research findings.
Actually, we can use part to generate the spectral moments, and these steps are included in your notes. If you are interested, you can refer to the notes. And we have analyzed for English foreigners fricative, including F, S, TH, and SH with part. And here are the results of the spectral moment analysis. And you can see that the curve shapes among these four fricative are different. And this table shows the summary of the findings. And from the table, you can see that S fricative has the highest M1 value above 6,000 Hz, and TH fricative has the highest M2 value above 3,000 Hz among these four fricatives. And do you know why they do have the highest value? And you can think for a while, and I will give the answers later. We have found a paper conducted by Lian or in 2006 to use the spectral moment of S to describe the gender identity from an environmental perspective.
As Jay mentioned before, the production of fricatives make two construction points and create two cavities in the vocal tract. And it is believed that speakers with different sex and age could have variations in biological foundation in terms of their vocal autonomy and physical size for the production of fricatives. So the special characteristics of fricatives among different speakers could be varied. In this paper, the first three movements were used to evaluate acoustic variations in the fricative S, and M1 and M3 have been shown to be sensitive to speaker sex or gender. As mentioned before, M1 is the central tendency of the energy distribution pattern, and it is negatively related with the length of the oral cavity. So compared to males, females have a relatively smaller oral cavity, so they have a higher M1 value. Also, M1 is indicative of the relative tongue position and in the oral cavity when making the construction. So from this, we can explain why S fricative has the highest M1 value, and you can fill in the table in the notes. S fricative makes the construction at the alveolar ridge, and it has a relatively small oral cavity, so S has a large frequency region as higher frequency. As a result, S has a higher M1 value. For M2, spectral standard deviation, it is sensitive to the size and shape of the lingual construction in fricative production. So the reason why TH fricative has a higher M2 value is that TH fricative has a greater contact area in the production than S. S fricative only involves the tongue tip in the construction, leading to a less contact area. So TH fricative has a more diffuse special shape, giving a rise to a higher value of M2. M3 is the degree to which it is skewed. Higher or positive values of M3 indicate more energy below the spectral mean, while lower or negative M3 indicate greater amount of energy above the mean. So females have more energy at high frequency regions, so they tend to have a negative M3, and males tend to have a positive M3. For the methodology part, there are in total 157 children aged from 4 to 16 years participate in the study, and these children were divided into 3 age groups, including early childhood, middle childhood, and adolescence. And children were asked to name the objects with the beginning of S, such as salad, sandwich, and cereal, etc. And the researchers record and analyze their speech using spectral moments. And here are the results, and you can see from the table, generally a girl has higher values of M1 and M2, but lower values of M3. And the difference became enlarged with the increase of the participant age. Also, M1 and M3 were found to interact significantly with the speaker's sex and age. Now I pass on to Kamei to talk about spectral analysis in Mandarin populations.
Thank you, Nicole. So in Mandarin phonology, spectral moments are also used for analyzing the affricates. So for these questions, I think every one of you know the answer, so I just show you the answer. So one of the recent studies used spectral moments to analyze the affricates production differences between the repaired cleft palate speakers and typical speakers. So cleft palate speakers also usually have the difficulties in speech, hearing, feeling, maxillofacial development, and the speech problems associated with them are usually phonological disorder, misarticulation, abnormal resonance, and nasal emissions. Affricates are a combination of stop and fricative articulatory components. Studies of English, Cantonese, and Putonghua reveal that speakers with repaired cleft palate demonstrate more misarticulation in affricates than other methods of articulation. So in Mandarin phonology, there are 3 pairs of affricates, and they are alveolar affricates, retroflex affricates, and alveolar palatal affricates. So in this study, the researchers would like to look into the spectral properties difference between aspirated and unaspirated affricates produced by typical Mandarin speakers.
apart from that, they want to also analyze the spectral properties of all 6 affricates in Mandarin produced by repaired cleft palate speakers when comparing to the typical speakers. So here comes to the methodology of this study. 14 Mandarin speakers without cleft palate and 14 speakers with cleft palate were recruited for this study, and extra 10 typical native speakers were recruited as the control group. So in this study, only first spectral moment, the M1 was examined because their previous study shows that M1 has a stronger ability to flag the place deviation in articulation. So here comes to the result. The first finding in this study is that typical speakers have produced an aspirated affricate with a higher M1 value, as I just circled in here. So the second finding is that 4 out of 6 affricates produced by cleft palate speakers show relatively low M1 value than the typical speakers. And there is no significant difference between 2 groups for the other 2 affricates. Typical speakers have a higher M1 value when producing affricates. This implies that there is a high average energy value during vacation period of affricate production. And for speakers with repaired cleft palate, they have a lower M1 value for 4 affricates. This may mainly due to the shift in position or degrees of vocal constriction. Mean spectral value reflects the vacation noise in anterior cavity before the constriction position. If the constriction moves backward, the anterior cavity will be enlarged, and this will result in decrease in spectral means. Usually in cleft speakers, they usually have posterior articulation because they use it as a compensation for their vilopharyngeal incompetence, deformities in dentition and occlusion, and therefore they have a lower M1 value for when producing the affricates. So after reviewing this study, we found that this study contains very small sample size for analysis, and the researcher didn't include any information about the speaker's physical characteristics, and they didn't mention other possible factors that will affect the spectral features. So we think that there is a need for further researches on this topic. So now I'll pass the time to Sandra to talk about the clinical application.
So actually, spectral moments contain 4 measures, but it's a bit hard for us to find really definited evidence for the use of spectral moments. So we applied this in 2 more papers about 2 different disordered populations. The first one actually is the same article used by Kansas group, but our focus is different. Instead of the vowel and fricative duration and intensity, we'll focus on their use of spectral moments here. And actually, this paper aims to explore the acoustic features of fricatives, voiceless fricatives produced by Parkinson's disease patients. And according to literature, when producing as PD patients usually had reduced elevation of tongue blade towards the alveolar ridge, so the result is less frication noise and less precise articulation. And he recruited actually 10 PD patients, and there should be 9 healthy control because there's 1 dropout. And the result is, we go through the method first, and I think Emily has also repeated already. The target word is sign and shine. So each participant has to repeat 10 times. The researcher measured the temporal part, the duration, and also intensity, and they do a second analysis on spectral moments, that is M1 to M4. So let's see the results. It is conclusive that frication, that is the consonant durations in PD group, were shorter than the healthy control groups, but the vowel durations in PD is much shorter than the healthy control groups. Intensity is similar, consonant vowel intensity difference between the 2 groups. And for spectral moment analysis, let's have a look. Actually, it's not very conclusive. In this experiment, we see that the line above HC is the healthy control group, and the lower part is the PD. And actually, they definitely show a smaller M1 value, but the pattern, the change pattern is similar. It is the 0.123 is the duration during which the patient say the shine word. So the onset, medial part, and the offset. So the pattern is similar. In conclusion, I would say that this paper, of course, is limited by its small sample size, so validity is in question. And in overall, temporal measure is a much better diagnostic marker than spectral moments in recognizing the features of voiceless fricatives in PD patients. And then we'll go on to another group about profound hearing loss children who has fitted with cochlear implant. And let's have a look at the features. We know that children with CI do not have, most of them do not have oral motor disorder, but their articulation is result of deprivation of auditory input, especially when they have yet to develop language. So, so do you know that why do children with CI produce fricatives differently from normal hearing children? A or B? B, yes. So thank you for listening to my presentation. So you see in the slides that there's some characteristics of speaking impairments of clients newly fitted with CI, and I won't go into detail, but I would like to draw your attention to a study by Yang et al., production of word initial fricatives of Mandarin in prelingually deaf children with CI. And the purpose is to examine the production of Mandarin fricatives by this type of children so as to better devise suitable habilitation plan or training for this group. The target, the participants include 14 children who have been fitted with CI, and their longest device use is only less than 3 years. Some of them has fitted with CI with less than a year. And the age is 2 years and 9 months to 8 years old, all recruited in Beijing, so they should have grown up in a fricative environment with a lot of retrofax and velar palatal. So I won't give you this question because I think it's a bit hard. These are 4 target fricatives in the study. He would like to test the 14 children with the 60 healthy control, how they pronounce the labial fricative sound and the alveolar sound and the S sound and the retrofax. So remember, on the left hand side is the pinyin and the right hand side is IPA. So the result, M1. The study shows that there is significant effect for M1 here. For the black bars are normal hearing, and the lighter one is the CI group. And the normal hearing groups generally show a high M1 value. But CI, they follow the same pattern, but the M1 value is a little bit lower. So M2, generally the pattern is the same except the fricative S. You see the CI group has a larger M2 value. That means the distribution of spectral energy of the S in these CI children were less consistent. And M3, a very special pattern appears, and let's look at the normal hearing group first, the black bars. And so for S and X fricatives, it is skewed towards the high frequency region, that is negative values. But for the CI group, for the S sound, actually it produced it's skewed towards the low frequency region. So hope you remember what I said. If I said that the children produce a M3 figure with positive, what does it mean? Is skewed towards low frequency or high frequency? Low or high? Okay, good. So it's easy for you. So for M4, it's similar. And actually, they also tested 3 other measures, the fricative duration, amplitude, and also spectral peak location. In short, among all 7 measures, only normalized amplitude and spectral skewness, that is M3, are significantly differentiating fricatives among the CI children. So all in all, M1, M2, and M4 are not significant. So M3 is significant, has clinical value for improving auditory training. But because of the small sample, I think it needs to do a longitudinal study to really see how the CI children different after a longer period of device use and how will they change the fricatives. Okay, here are the end of our presentation.
Thank you.
好啦，全部都完成晒啦。咁我哋花少時間討論下你哋嘅感覺啦。咁我 individual group 咧，我唔會俾 comment 住嘅，咁我會喺 written 度寫翻佢嘅。咁不如你哋自己講下啦，你覺得完咗個 presentation 嘅 process 有啲咩改變啊？你哋對於個 presentation topic 嘅了解？係重要嘅。咁繼續問多啲 features 啦，我哋嚇。仲有咧？仲有咧？講晒啲好嘅嘢先啊，好嘛？講晒啲好嘅，應該有好多嘅。有啲咩優點啊 ？as a group 或者 as a big group？
我對自己嗰個 measurement 都幾了解嘅。
你變咗 expert 啦，係咪？直情係對自己 measurement 係啊。你變 expert 㗎啦，係啦。
我自己 abnormal swimmer。
但你冇 show 你嘅 abnormal swimmer 嘅 reading 㗎啫嘛，係咪？
有啊。
另外嗰個咧？另外一個係
normal 都有㗎。
OK， 有冇啲好嘅嘢講咧？仲有好多個喎，咁我哋講多啲嘢聽下。
逼我哋好短時間內睇好多 journal paper 咯。其實好好㗎呢樣嘢，好好，真係好。
即係個 outcome 都係好嘅，可能 initial 就唔好啦，係咪啊？辛苦啦。你哋最初咪話好似好難揾啲 articles 嘅，就係咁樣考係咪有揾到咧？即係有啲可能冇 candidate 曬，可能最先你哋揾嘅 article， 即係最撚尾你哋可能都冇用嘅喎，你哋用咗第二啲嘅喎，係嘛？即係你哋可能想用嗰啲，最尾呢份越嚟越揾之後咧，揾到啲更加即係貼題嘅，同埋你覺得可能係可以有啲更加即係 valid 嘅 articles， 有冇咁嘅感覺咧？其實好多嘢都係即係好多 articles 都係匿埋咗，我哋可能原先係唔知嘅。好，我哋你乜嘢太差咁樣講一次。入唔到嘅，因為我哋冇 resources 係嘛。但係如果係用 interlibrary loan 要幾長時間先攞到咧？3、4日得唔得啊？其實可以用過，有冇同我用過啊？有，但係要幾多日 turnaround 啊？大約係。
我試過3日到啦。
如果佢3日都係 acceptable 嘅 ，acceptable， 咁下次要多啲用，因為你哋應該係有好大嘅 quota 啊嘛，攞 interlibrary loan service。咁其實你哋記住喎，如果做thesis 都有類似嘅情況。揾到你咪即刻 request 咯，其實可能幾日就有㗎啦。因為 electronic world 其實好快嘅，咁我哋可能每一種 journal 因為太貴，journal 可能係1年幾萬蚊，所以我哋係放唔到嘅，即係 as a university，因為我哋唔係 medical school 啊，所以可能唔會有咁多 journal 咯。但我相信如果用 electronic request 咧，超 e-learning 咧應該係可以好快攞到嘅。咁講啲你哋自己好嘅嘢啦，同埋你哋應該可以 appreciate 到嘅喎，有好多嘢都好好喎，即係。無論係準備啦、visual 啦、present 嘅方法啦、interaction 啦，其實都有好多可以 comment， 可唔可以自己 comment 下咧 ？Time management 非常好啦，即係最多即係 overrun 咗10秒啫，係啦，所以非常之好嘅，所以我哋好有時間做 evaluation 啦。仲有冇？你哋係出 clinic 都係你 supervisor 問你有冇好嘢喎，如果你唔答即係冇啦，冇咁咪開始就講啲衰嘢㗎咯喎，咁最尾你嘅醫就會差㗎咯，明唔明啊？快啲啦，等你哋講啊！我話 love and silence 啫。
大家用一個好簡單嘅方法講一啲好深奧嘅嘢。啱啊！
深入淺出係咪？起碼我哋會明先啦，即係你 put up your slides 係嘛？仲有咧？
組員之間可以互補咯，即係有啲睇清法睇得好快，亦都有兩份 paper。
啲做 format 好叻嘅人幫手，係
咯，有呢個 friction 嘅 arrow 喎，你其實可以放大啲啊，可。唯一一組有自製嘅 animation 係嘛？係咪其實自己做㗎嘛係咪？唔係自製㗎，揾㗎。個 friction 嘅 animation 係自製㗎，我揾嘅。咁要 call 翻個 source 喎。咁我以為你係自製嘅添嚇。OK， 仲有冇第啲 ？As a big group 都好 supportive 嘅係嘛？大家仲覺得好開心嘅氣氛係，其實好重要嘅，因為即係可能因為都有 requirement， 大家要需要考啦，咁所以咧都好 involved 嘅，好專心，所以都會好 support 同學嘅。仲有冇第啲啊？喂，唔好我講晒啦，你哋自己醫下得唔得？係，即係揾咗啲自己之前可能唔係好知嘅資料啦，尤其係即係點用啦，係咪啊？係啦。咁 interaction 方面咧，我開心，係咪每一組都基本上有問題，有需要同學 involve 係咪啊？你以前 present 都有嘅應該係咪啊？都有嘅，咁非常之好啦。嚇？時間嘅關係。平時有禮物嘅，有咩禮物啊？
唔好咁樣，人最需要都係時間。
下次補翻啦，仲有下次啊，我哋。仲有下一次有一堂，唔係下一個嘥堂。我下一個週六都唔想見到你哋。
大家等我。
仲有咧，你咁樣，我覺得你啲 script 寫得好好咯，係咪啊？其實我寫 script 嘅係咪啊？寫電話度係咪？或者係 iPad 度，係咪寫 script 啊？寫字度啦，係啦，非常好嘅 script 可以幫到你哋咧present idea 嘅時就唔會咁多，好似我教書嘅時候咁多。
唔好咁
講。呢個非常之好嘅，係啦，咁可以 practice 呢 script 嘅方法，係啦，當你有時間就可以寫多啲 script 啦。仲有咧，仲有冇啊？我發覺有好多 table 嘅，即係喺個slide 上面係咪？其實有時候好多時候都唔使用好多字嘅，用 table 可以令到人一望埋去咧就知你比較緊咩，因為每一次你要比較呢用 table 其實係最容易嘅啦。如果你反而寫 point form 咧，我哋好難去 relate 到嘅，呢個非常之重要嘅。用顏色啦，係咪font size 都非常大嘅，即絕大部分嘅時候。咁但係留意有啲時候咧，如果你 cap 圖咧 cap 到啲好細，基本上睇唔到喎。尤其我哋老師咧老花嗰啲睇唔到嘅，咁你要留意下。睇唔到可能當你冇講過㗎咯嚇。仲有冇第啲？好嘅，你俾多兩個好嘛？俾多兩個好嘅。
有啲同學寫緊 notes，你話好易跟。
基本上我哋睇咗8頁就應該可以去考試啦，就唔使再揾翻原本嗰個 reference 嘅，贊唔贊成㗎？睇埋 PowerPoint 係咪啊？係。所以其實我哋做 notes 嘅時候，如果我哋上次咪討論過可唔可以齋 point form 定係可唔可以一定要用翻 APA format 咧？其實你諗下，如果你嘅同學淨係俾啲 points 你讀，其實同你睇翻佢個 PowerPoint 應該係冇分別嘅喎。咁所以如果你可以用翻即係APA 或者係 paragraph 嘅 format 咧，去 introduce 你嗰啲 points 咧，咁佢就會易啲明白咁樣咯。呢個係重要嘅。所以諗下點樣去用最短嘅篇幅啦，同埋最容易明嘅方法，譬如加 table format 喺個text 度咧，令到同學易啲 understand 你嘅 concept。咁我哋基本上我相信大家都唔需要再揾翻個原本個 reference 去 study 㗎啦，即係 for 呢8種嘅 analysis 嘅 method 係咯。俾多個我啊，你做得好嘅地方。嚇？有自信其實每個同學都非常之好喎。我見到差唔多咧，你個 time allocation 咧都係5分鐘同學到咯，其實係非常之 even 嘅。係咪有 practice 過你哋？有冇 dry run 過啊？dry run 要幾多次啊？一次都非常之好啦，其實非常之好。我就唔 expect Year 1同學可以咁清楚嘅，即係 present 得。 嚇？我唔係 expect 你睇 undergrad。有好多人present嘅經驗係嘛？咁啊，多謝你哋謝老師啦。嗱，仲有冇第啲？嗱，如果講晒啲好嘅，不如講啲你哋覺得要有改進嘅地方啦，好唔好啊 ？As a group， 我哋唔偏開某一個某一個 PowerPoint 或者某一個 group 嘅我哋講翻 in general， 或者可以講自己嘅，有啲咩可以再做得好啲嘅，再 present 嘅時候未來。
我諗都係掌握，即係你話係 expert， 但係就算係我 focus 喺嗰個 measure 度咧，都覺得掌握得唔足夠。即係所以分析嗰啲 paper 究竟佢有用定冇用定，即係去試下去 critic 佢或者 evaluate 佢嘅時候咧，我覺得都係有啲限制，可能啲形式個 topic 都唔夠咯。
咁呢個都係一個學習嘅過程嘅，所以唔需要太過覺得自己唔足夠啦。起碼你要 appreciate 自己學識咗啲乜嘢咯。相比於之前，你哋可能我哋 assign topic 嘅時候，你可能完全覺得呢樣嘢係唔明㗎嘛，但係你而家明咗幾多㗎咯喎，相對上係咯。仲有冇第二啲？我哋不如講係performance 就唔好講 knowledge 住啦。你覺得 performance 上面有啲乜嘢可以做得再好啲嘅？不如講下 presentation style 啊，有啲咩可以再好啲嘅？
可以有多啲 intonation 咁樣。
你好多㗎咯喎！嗱，大家要跟佢啦，佢要好似佢咁多。即係主要等大家咧 keep 住唔會瞓着，明唔明？其實咧好易瞓着嘅，我坐喺度我都易瞓着，除咗唔寫嘅時候。所以你諗下咧，點樣去做個 baseline，跟住突然之間咧有啲高潮嘅位係咪啊？喺唔同嘅時段嚇，同埋咧記住你係個 floor 係你㗎嘛，你其實去到後邊咧都係你嘅個地方。你諗下可以點樣用咯？即係成個間房都係你嘅，你諗下點樣 engage 你嘅學生？譬如如果你成日做 group work 咧，或者 classroom 之類咧，全個課室啊，全個課室，仲有冇第二啲？咁記住個 baseline 就係如果你一路都係好大聲同埋好高嘅，即係 intonation change 咧，突然之間你想再 highlight 個 point 咧，你可能已經冇空間再 highlight。所以記住有 fluctuation 嚇，俾啲 pause 學諗嘢啦，可能啲 silence 嘅時間，即係可能幾秒已經夠㗎啦，係啦。我仲有一個 point 嘅就係pronunciation。嗱，我哋唔係好多同學都唔係 native 啦，如果 native 嘅就可能唔使咁擔心啦。記住咧，如果你唔係好肯定嗰個字點讀咧，你要 search 下點讀先，係啦。因為咧其實我哋好 accepting 嘅，即係我哋 teaching staff。但係如果你出邊咧，譬如你見 supervisor 啦，或者係見一啲可能對你唔係十分友善嘅人咧，其實佢可能淨係用一個字就 judge 你咧嘅 performance 啦。咁我覺得呢個唔係好 fair 嘅。咁所以如果你發覺有個字唔識讀咧，最好唔好讀，或者你 check 咗先好讀。咁呢個係 protect 你自己嘅image， 即係 public image 係啦。所以咧，我覺得大家要諗下，究竟呢個字我咪肯定咁樣讀先？如果唔係嘅話咧，不如我 search 咗先好 present 咯。咁我其實呢收咗一辣嘅字嘅，咁我會 type 翻俾大家，你自己揾下嗰個字點讀，係啦，你自己諗下係啦，咁你自己翻去 search 翻。我覺得唔需要逐個字教，因為大家可以 search 有 search engine 可以 search 噶嘛。所以記住，因為未來咧，你仲有更加多嘅 terms 咧係唔識讀㗎。你入到醫院咧，其實如果你讀錯字咧，你就會俾人恥笑。即係我唔係話每一個 supervisor 咧都係好 harsh， 但係最好 present 自己係一個好啲嘅 position 先咯。係咪明啊？呢個好重要嘅，呢個重要。即係如果大家同學就冇所謂啦，但係出邊咧，人哋就會用好少嘅嘢去 judge 你。譬如話你點解你會冇着襪㗎？譬如西褲唔着襪㗎，或者其實你嘅儀容點啊？會唔會男仔留長髮啊？或者你有紋身啊？甚至係有啲咩特別嘢？其實好少嘅地方咧，人哋都會去 judge 你。咁我就覺得咁樣就唔係一個好 fair 嘅 嘅 judgment 啦，但係最終我哋就避免咗呢啲即係俾人 unfair judge 嘅機會，好嘛？仲有冇第二啲啊？覺得可以做得好啲嘅地方？可以放鬆啲，其實好放鬆，我覺得大家都 OK 嘅，即係感覺你好放鬆啦，就唔係好緊張咁樣，係啦。點樣可以再放鬆啲咧 ？floppy 啲，點可以再放鬆啲咧？咁其實你哋 present 嘅時候，你個 focus 係咩嘅？你個 focus 係咩嘅？focus 個 task 嘅 focus 係乜嘢咧？
係教學咯，唔係 present 咯。如果你咁諗就會放鬆。
邊度講嘅呢樣嘢？非常好啊，俾掌聲。你嘅 focus 即係如果你係 transfer knowledge 咧，或者 share knowledge 咧 ，rather than focus 自己 perform 成點咧，其實你會 relax 啲嘅，因為呢個係你嘅 main focus 啊嘛。其實未來都係咁噶啦。如果你不斷諗下死啦，我正話講嘅説話咧，會唔會係得罪咗家長啊？或者個小朋友會唔會喊啊？其實你永遠都冇可能 focus on 你自己即係 existing 嘅 task 嘅。你目的就係去幫佢啫嘛。就算佢哋喊好難搞，其實你都係幫緊佢。咁基本上你都係做緊你應該做嘅嘢啫。所以你要諗下點樣去 mindful 啲，即係活在當下。如果你太過擔心自己 perform 成點咧，其實就已經攞咗 resources 㗎啦，攞 resources 㗎係啦。同埋留意咧，用個咪啊，用個咪。如果咧有啲同學咧，可能佢有啲緊張啲，大家聽唔到咁樣咧，其實啲賊嘅係嘛，咁就會唔係幾好啦。對於個 audience 嚟講係嘛，如果咁啊太細聲啦，所以可以有時候會 check 下後面咧，其實聽唔聽到你都問下後面嘅 feedback 咁樣咯，好嘛？咁我冇嘢講啦，大家仲可以補充。咁啊，恭喜晒大家啦！全部都做得非常之好嘅。咁我下次見大家會補翻啲咩話？補翻啲獎品啦嚇。多謝。OK。好啦，咁我哋26號係咪先再見咯喎？係咪啊？星期三，大家需唔需要9點鐘 tutorial 啊？咁不如我俾 email 大家啦，如果大家需要嘅話呢有一個同學想，我都會開嘅，好嘛 ？OK， 咁啊26號記住帶電腦嚇，同埋撈曬 part 嘅 software 同埋我之前所有嘅一啲practice files。好，大家有個愉快嘅 Easter 嚇，有個愉快 Easter。
係咪嗰一條 條唔知咩 somatic effort 我睇係啊，嗰題撞到。其實一個係關係上後尾又揾個小朋友買嚟，就攞出嚟。係啊。